Good evening, everyone. I, on behalf of the Assam Chapter Society of Fetal Medicine, extend a warm and hearty welcome to the faculty, panelists, and attending delegates of our first virtual quarterly meet 2020. We have an interesting evening of great academics lined up with 2 talks and a panel discussion. And it is indeed an honor for me to welcome Dr. Ashok Khurana, sir, and I thank him for taking the time out on a Sunday evening to be with us. Khurana, sir, is the main pillar and backbone of the Society of Fetal Medicine, an excellent teacher and academician. A visionary, Khurana, sir, is the immediate past president of SFM and has been the main force and inspiration behind the formation of the Assam chapter last year. And he, along with the present President, Dr. TLN Praveen, and Vice President, Dr. Mohit Shah, has given us a very successful inaugural CME in February. It is also my proud privilege to welcome our 2 guest speakers for today, Dr. Bimal Sahani, sir, who is the President-elect of the Society of Fetal Medicine, and Dr. Shyam Baruah, sir, who is the President of the Assam chapter. I would also like to welcome our panelists, Dr. Shyam Baruah, sir, Dr. Saswati Sanyal Chaudhary, Dr. Apurva Bhattacharya, Dr. Nilakshi Fukan Kumar, and Dr. Ruby Buragohai. Before we begin our academic session, I would like to request Dr. Khurana, sir, to speak a few words and inspire us all. Over to you, sir. And thank you so much.
Thank you. Thank you, Gina. It's nice to be here. And I'm trying to see whether I'm still on because, yes, there we are. Yeah. So it's great to be here. And you know, I always believe that Sunday evenings are family time. And believe me, SFM is as much a part of my family as the biological family. And thank you so much for giving me this privilege. It's been a pleasure seeing the Assam Regional Chapter grow with Shyam as the lead and you pushing it in all directions along with a very strong team. And we were very impressed with this when we did the inaugural on-site meeting a few months ago. I knew we would go far and I'm sure we've come far. But one of the most exciting things that I noticed today is that in spite of 2 consecutive nights of the same topic, which is fetal growth restriction, we still have an overlap of the attendees that I see attending both meetings. And this is most interesting. When you chose it, I was wondering, should we keep these meetings back to back? We have one on Saturday night, we have one on Sunday night, and would it be too much of an overdose and we'd miss out on audience for both and people won't be able to get the time to digest any of these? And you know what struck me? It struck me that yes, we must accept the fact that 1 out of 4 pregnancies has growth restriction in our part of the world. We do understand that it's a mess during pregnancy, that it's a clinical mess during the perinatal period, and it doesn't stop there. We do understand that growth restriction goes on and on and on. It kills us with metabolic syndrome, insulin resistance, polycystic ovaries. It kills us with type 2 diabetes. We get completely destroyed by the onset of cardiovascular disease at a young age, and we have to strike somewhere. We learned last night that there are protocols which clearly indicate that we need to adapt to local needs and not just an international protocol, which is purely an advisory. And I'm so glad for giving it the local flavor, we've chosen the right faculty. We know that the faculty tonight, and I'm really proud that they're such integral parts, are actually the ones who have guided us, the ones who have inspired us, and who have ensured that people at various levels of specialization and expertise can ensure an optimal outcome for every fetus. It's not merely referring on and washing our hands off. There's much more to fetal growth restriction than referring to fetal medicine or referring to higher center as we tend to do in our part of the world. We will, after this series, realize that yes, we do need guidelines, and I'm really glad that Dr. Bimal Sahani is going to take that forward. We had a chat last night and we said we have to take this forward, and he's going to take the lead on this, and I'm looking forward to his presentation. What we have also succeeded in doing tonight is to bring an equal number of practicing obstetricians on the same page as those who actually do fetal medicine and ultrasound scans. We know there's an overlap in the people who do ultrasound scans. We know there's an overlap of people who give advice. But importantly, we've now brought everybody on the same page so we speak the same language. And that really is what we need to do. So thank you so much for arranging this. I greatly appreciate how you have moved rocks, boulders, mountains to put together the regional chapter that you have. And I'm so glad Shyam has always been there to guide you forwards, to push you forwards, to pull you forwards, and to keep you there. And thanks to the team for putting this together. We now move on to academics. Thank you very much.
Thank you so much, sir, for your constant guidance and encouragement. So now we begin with our academic program. And our first talk this evening is by Dr. Shyam Baruah, sir, and he shall be sharing his experience on scanning beyond the 3-vessel tracheal view of the fetal heart. Shyam Baruah, sir, has done his MD in radiodiagnosis from PGI MER Chandigarh and is the senior consultant and director at Ecopath Center, Guwahati. He has several presentations and publications to his name and has been invited as faculty in various conferences at both the regional and national level. A fantastic teacher and an academician, Shyam Baruah, sir, is one of the pioneers of obstetric ultrasound in the Northeast. And today we are really looking forward to hearing him speak. Over to you, sir.
Thank you, Gina. Thank you very much. Share the screen. Share the screen. Good evening, delegates, panelists. Good evening. Can you hear me?
Your screen is not shared, sir.
Screen is not shared.
Yes.
Switch off the video first. Switch off the video. Video to focus correction, sir.
Video to?
Yes, it's
Yes,
come, sir.
marvelous.
Yeah.
Excellent. And if we could go to, yes, the full screen, bottom of the page, bottom right next to the volume. Perfect. All set to go. We see the screen very well. We're waiting for the sound now. I'm sure we shall be organized in a few minutes. And it always reminds me of the fact that, yes, there is always adaptation involved in new marriages, and we have to follow those. I'm just saying, okay, let Dr. Shyam take those few minutes to make sure that we get the sound right. I see some exquisite videos right there, but we really need to hear him. Are the others able to hear him, or am I the only one not able to hear him so far?
We are not able to hear him, sir.
Ah, okay. I think we should be a minute and then we should be able to hear him. We have.
Itu খুলিলে আহি যে আকৌ নাইকিয়া হৈ যায় যদি মই এখানে তো দিগদাৰ পাইছো
We did hear some sounds right there. Should we go ahead with our first talk instead while we get the sound organized? Should we flip the order of the talks?
I think because he was not speaking at all actually. He didn't start speaking. He had his slideshow on.
Yeah.
Now he's. Hello.
We can hear you, sir.
Yeah, you can hear me, but Dr. Baruah
can hear us. Yes.
Dr. Bimal, would you like to start, sir?
I don't mind, but it just ask him once, Gina. Oh.
I think we should take a decision and flip the talks perhaps so that we can get going and not keep our attendees waiting. And we have plenty of time really to have his talk at any time when we've checked out the system. Gina, what do you suggest? Were you able to get through? If you can unmute.
I couldn't, sir. I think he muted his phone. So I think we should start with Bimal Sahani sir's talk and then he can get it sorted out.
Yes, of course, certainly. Yeah. So that's what we will do.
So we move on to our main topic for this evening, that is fetal growth restriction, diagnosis, surveillance, and decision-making by Dr. Bimal Sahani sir. Dr. Bimal Sahani is a radiologist and director of SONOSCAN Center, Aurangabad. He is the president-elect of SFM, academic coordinator of the Scholar MD Fetal Medicine Training Program. He has several publications in his name and is a regularly invited faculty to various national and international conferences. An erudite teacher, sir has a passion for teaching, and we shall soon experience it in the next hour or so as the meeting progresses. So over to you, Bimal, sir.
Thank you very much, Gina, and thank you, the complete team of SFM Assam, for giving me an opportunity to be here. Your chapter, is actually, in a very, very short time, you people have taken it to a very, very high level after a very, very successful, huge meeting on site and then coming up with your first virtual program. And my congratulate you all for that, and I wish you that you keep on going ahead with such wonderful programs in future also. I'm going to take you all through fetal growth restriction. Now, like Khurana sir said, that in 2 consecutive days, but people still want to come and listen, because actually it's a complicated topic. It is a complicated topic because there are a lot of things which are still not very, very sure how to manage certain aspects of that. And what you learn 6 months back may not be relevant 6 months later. So there is so much of work which is going on fetal growth restriction that you just need to keep coming on and on to learn what is the new evidence that has come up. So that is one reason. And again, a lot of research comes in which we may not be able to put into clinical practice. So what is there is something that we need to, formulate, which probably everyone in our country can follow, which is simpler and which is acceptable, and based on whatever is available at every place, a proper decision can be taken. So I start with that, do we really need to address this issue, fetal growth restriction? Now, see, FGR is known to be associated with increased perinatal mortality and morbidity. It's not just about, a baby, a stillbirth, or an immediate neonatal morbidity. It's also, FGR babies can have non-communicable disease in adulthood, hypertension, metabolic syndrome, insulin resistance, type 2 diabetes. And as Sir said, 1/4, so that is nearly 26 to 30% of pregnancies in India have small fetuses. Now, if you look at this chart, you will find that's the prevalence of trisomy 21, 18, 13, and then you look at severe FGR. So this high is the prevalence. Now, so this is one thing. Actually, a few years back was a neglected entity. If you have been to any conference about 3 years back, there'll be one whole day on down screening, one whole day on cardiac anomalies, and hardly 1 or 2 small short lectures on fetal growth restriction. And Society of Fetal Medicine actually has taken up this wonderful step, I would say, in the last few years, that we have made the whole country start thinking about fetal growth restriction as a very, very important entity that we all need to address. Because if you look for a parent, see, we talk about trisomy 21, a Down's baby, or aneuploid baby can cause death, it can cause disability. Can fetal growth restriction not do the same? Yes. If there is an acidotic baby, or if there is a growth restricted baby who has not been brought out on time, that baby will also remain a vegetable all his life. So for a parent, it does not make any difference whether it's a Down's baby or a FGR baby not brought out on time. So for all of us, it becomes mandatory that we need to take this topic very, very seriously. And I'm not going to take you through a huge lot of confusing data. I'm not going to take you through a lot of research. I have tried to simplify it as much as possible so that, it's not just about a few super brains who try to absorb something, but everyone, even practicing in smaller places, can put it into use. But before I get into it, there are some very important aspects of growth. First of all, growth and size are not the same. See, that is one mistake we make. We feel the size that we take on one occasion. So size is something that you're doing on a single occasion. So today, if I'm doing a scan, I'm looking at the fetal size. But that actually does not tell me anything about the growth. Actually, growth implies velocity. So growth is a change in size over a period of time. So biometry is something on a single occasion. Growth is a change in biometry over a period of time. And this can be assessed only by longitudinal measurements. So like this is, you get a report like this. These are all the measurements there, Likert borderline low, and sent for growth scan at 32 weeks, gestational age by USG 29 weeks. Can you make out anything about growth on this? Definitely no. Now, you can never be happy with this. Is this better? Yes, it is somewhat better because at least it's telling me the percentiles where things are happening. But again, it does not tell me much about the growth. And what about this? So this is something where how is this, the longitudinal growth has taken place and how the fetus has been growing, whether there has been a dip in growth there. So I start this talk actually with just one example. You have a 34-weeker. There are two fetuses, fetus 1 and fetus 2. The gestational age is 34 weeks for both. The fetal weight is 1740 grams, which is at the 5th centile for both the fetuses. Fine. Now, if you look at a scan which was done 2 weeks prior, in fetus 1 at 32 weeks, the fetal weight was 1570 grams, which was at the 5th centile. whereas in fetals 2, it was at the 12th centile. Now, which is the one that you're going to be more worried about? Okay, this was at the 5th centile, this has remained at the 5th centile. So it has been growing at a lower centile, but the growth is linear. Whereas if you look at this, this has gone in from the 12th centile to the 5th centile. So this is the fetus that I would be more worried about. And that is why you have to, I make a very, very sincere appeal for growth charts. So there is nothing in growth without growth charts, and growth charts should become an integral part of your practice, whether you are an radiologist doing ultrasound or in obstetrician doing ultrasound. Growth chart is something which is necessary for making a good diagnosis of growth restriction. So I will take you through definitions. I'll take you through normal and abnormal Doppler waveforms because there are a lot of PGs here. Then we'll discuss between SGA and FGR. We'll talk about early onset and late onset FGR. We'll talk about staging of FGR and decision making on when to deliver. Now, there are two things, SGA and fetal growth restriction. Unfortunately, we have been using this as a synonym. We're using both as a synonym, but they're different in the sense an SGA is a small fetus. Now, it's very easy to define an SGA. That's small for gestational age because it's a statistical deviation from normal, and we say that any fetus with an estimated fetal weight less than 10 centile is SGA. Okay, you had different opinions, less than 5th centile, less than 3rd centile, and all those things. But now, general consensus, yes, any fetus which is less than 10 centile is a small fetus, is a SGA. But is every small fetus a fetal growth restricted fetus? The answer is a big no. Every small fetus is not a fetal growth restricted fetus. In fact, 75% of the fetuses are normal small fetuses. 70 to 75%, 10% are fetal growth restricted, but that is because of an intrinsic problem in the fetus, either because of abnormalities or because of infection or because of aneuploidy, and 20% are because of the uteroplacental insufficiency. So the cause is uteroplacental in 20% of them. So every SGA is not a fetal growth restricted fetus. And that is why we need to differentiate between these two also. So what is the definition of fetal growth restriction? Now, yes, a few years back, we came up with a definition that a fetus that has failed to achieve its genetically determined growth potential is FGR. But now the consensus is that a fetus with an estimated fetal weight less than the 10th centile on ultrasound, that because of a pathologic process has not attained its biologically determined growth potential. So that actually is an FGR. So that is, if it is because of a pathologic process, then we would call them as FGR. The problem is that failure to attain growth potential is a concept which is very difficult to gauge, and hence what we are actually doing is we use fetal size as a proxy, though it has its all limitations, but then that is what we are doing at the moment. So fetal smallness is fetal weight less than 10 centile for gestational age. Now, please let me tell you, I want to rub this point into everyone that it is 10 centile of the gestational age, not of the ultrasound age. So every time that when you put in a fetal weight on a growth chart to see at what centile it falls, you have to look at what is the, first you have to decide what is the gestational age and then see whether the fetus is falling less than the 10th centile for that gestational age. Hence, the most important thing in diagnosis of fetal growth restriction is a correct gestational age. And why is it that we are not picking up, we are not recognizing these small fetuses? There are a few reasons for that. This is what I have learned over practice. What are the reasons why, why we are failing to do it? Either the dating scan has not been done or the dating scan has not been reported. Now that is also a very, very common thing. You ask a patient, have you got a scan done in earlier pregnancy? They say, yeah. Where's the report? No, they didn't give the report. They just saw and they said, yes, everything is fine. Now that kind of a scan is of no use to me because I have nothing to say what was the, what was the CRL at that stage, whether it was corresponding to the menstrual age or not. So that actually is one of the major reasons. The second most important reason is that I don't know where this concept came from, but in fact, 90% of the people, they give the sonographic age as the gestational age at every scan. So today, if the menstrual age is 32 weeks, and if the ultrasound is showing an average 29 weeks, they'll report it as 29 weeks of gestation. Now, if you do that, how are you going to pick up fetal growth restriction? So unless you don't say that this is 32 weeks of gestation and my parameters are at 29 weeks, that means the growth is lagging behind. That means this is fetal growth restriction. And then one more reason is that nobody wants to look at the previous file of the patient. Because the problem is the early scan is done by someone, the NT is done by someone else, the anomaly scan is sent to someone else, and the growth scan comes to someone else. Now everyone, they do their scan, nobody bothers to go and check into the file before and see, yes, what was the CRL at that stage, was it corresponding, was it not? Nobody wants to put that time in, and so whatever is available, whatever is the screen showing, okay, the screen is showing average age 29 weeks, you write down 29 weeks and the story ends there. Because now, if I look into every file, if I look into, at least 60% of the files which come to me, if I look into it, the patient has got at least 4 to 5 EDDs. Because every scan, there is a different EDD that has been given. Now, how is it possible, So dating scan is most important. Remember one thing, this is the most important message I'm giving today, that once an EDD has been assigned, do not change it in subsequent scans. Relate the subsequent scans to the corrected EDD. What I'm trying to say here is that when you are asking the fetus during the dating scan, how old are you? So that question has to be asked only once. Only once you can ask that question, how old are you? Suppose you are moving in a market and if you find your friend and your friend has got a baby in her arm and you say, okay, how old is your baby? And she says, my baby is 6 months old. Now, if you meet the same friend after 6 more months, are you going to ask again, how old is your baby? If the baby was 6 months old 6 months back, the baby has got to be 1 year old today. The same way, if you again ask the fetus, how old are you? The fetus will think, we are not good enough. We are stupid. The only thing, the fetus cannot talk, but the fetus would have said, I've already told you my age last time, can't you calculate? Why are you asking my age again and again? So after the first scan has been done, whichever was the first scan, well, maybe a CRL, if there was no CRL done, then the second trimester, whenever you have once assigned a gestational age and an EDD, you are not going to change the EDD again. After that, every scan, you're going to ask only one question to the fetus, that, my dear, are you growing well? That is the only question you're going to ask. So, as I said, 70% of the small fetuses are basically normal small fetuses. So we need to really differentiate between the small fetuses and the fetal growth restricted fetuses. So because now we have already agreed on that all SGA fetuses are not FGR. So we have already talked about that. There is another thing I want to tell you. Are all FGR fetuses SGA? Even the answer to that is no. Because we take 10 centile as a cutoff. So we have, yes, definitely all those fetuses which fall less than the 10 centile are more likely to have some problem. But there can be fetal growth restricted fetuses who are above the 10 centile also. So you can have an FGR, fetal growth restriction, with SGA and also with AGA. So you can have an AGA fetus who's also fetal growth restricted, but that is something which is there's a lot of work going on that, and that is something which is a little complicated. So what we will do is, I will come to that at the very end. I'm not going to speak, because whatever the protocols and all have come so far, which are well established, whatever is controversial, whatever is not known, we will speak at the end. But we will speak about an FGR, which is SGA. So we have a small fetus, we have got the biometry, we calculate the fetal weight, and we put it on our growth, on the fetal weight chart, and see at what centile the fetus is falling. Now, before we go further, actually Gina wanted me to take a little bit on the Doppler waveforms and this thing. So first of all, when we have any Doppler waveform, fortunately, we are really not too much dependent upon the angle and everything, because we are dealing with indices. Now, I'm not going to get into too much about the indices, but only thing that I want to tell you is, forget your RI and SD ratio. The people who are still over the years, because I don't blame them, they've been used to the SD ratio before, but you have to forget your SD ratio and remember only the PI, because whatever work is being done in the world at the moment on FGR is related to the PI. It's got nothing to do with the SD ratio and RI, because PI is the one which shows linear correlation with vascular resistance, and it does not approach infinity. That is a very, very important thing. Now, whenever I ask questions to my students, and when I ask them, uterine artery, is it a placental test or a fetal test? 100% they say it is a placental test. But whenever I ask them, okay, umbilical artery, is it a placental test or a fetal test? They say, no, it's a fetal test. But let me tell you, both uterine artery and umbilical artery are basically placental tests. They are telling you nothing about the fetus. So the umbilical artery is also telling you what is the vascular resistance at the placental level. So it is not telling you anything about the placenta of the fetus. Fetal MCA and ductus venosus studies, these are the ones which are fetal tests. They are the ones which are telling how is the fetus responding to the adversity that has come in. So MCA and DV are fetal tests, and uterine artery and umbilical artery are placental tests. The uterine artery tells us about the uteroplacental impedance, and the umbilical artery tells us about the placentofetal impedance. Then uterine artery normally has a high resistance flow, but as the gestation increases, the diastolic flow increases, this notch which you see in the uterine artery disappears. But if you find that later on in pregnancy also, you find that the diastolic flow is still low, it's still showing a high resistance flow. Now remember one thing, the notch has gone for a toss. Definitely, yes, if okay, you have a notch, it gives you some kind of an additional thing that this can be a problem, but then there's a lot of issues with the notch. How deep should it be that we should call it as a notch and all? So what is one general consensus is that we don't bother about the notch, we just think about the uterine artery PI, and that too, it's not about which side, the right side or the left side or the placental side or the non-placental side. We only say we take a mean of the two, and there are charts for the mean uterine artery PI, and a mean uterine artery PI more than 95th centile is abnormal. As far as umbilical artery is concerned, umbilical artery normally will show you a high diastolic flow. That means normally the PI would be low. But as the peripheral vascular resistance in the at the placental bed increases, you will have, so it goes through a cascade of events. So umbilical artery goes through a cascade of events. So you will initially have high resistance flow, that is the diastolic flow is less, so the PI increases. A stage will come when you can have absent diastolic flow, and eventually you can have reversal of diastolic flow. So absent diastolic flow is telling us about hypoxia, reversal diastolic flow is telling us about acidosis. MCA is normally going to show you high resistance flow, so the PI normally is high. But again, now this is what is happening. There is less amount of perfusion which is coming from the placenta, less amount of oxygen coming to the placenta. So more blood is being pumped to the brain. That is what we call as the brain sparing effect. And when that happens, the diastolic flow in the MCA increases, so the MCA PI goes down. So, and then of course it can happen at a stage when the fetus is absolutely, fetus is acidotic, and everything that there can be a paradoxical, deterioration, and you may, the deterioration may stop, and you may have that the MCA PI may start increasing, and that of course is a very, very end stage problem. We don't want to reach there. We don't want to get our fetuses into that stage. Very important vessel is ductus venosus. Technically a little difficult. You need to get used to it. Normally, now what is important in the ductus venosus is this A wave. That is the A wave. That, normally you will find that's the normal A wave. You can have a deep A wave, so decreased A wave, where the ductus venosus PI. So you have venous PIs also. The charts are available on the net. A DVPI of greater than 95th centile. Now, as the fetus becomes more and more acidotic, you will have an absent A wave, and at the end stage, you will have a reversal of A wave in the ductus venosus. Coming down to aortic isthmus, again, a controversial thing, whether to use aortic isthmus or not to use aortic isthmus. Yes, we are still using it. There are two different school of thoughts. But what is aortic isthmus waveform? Now, you can get it from the 3-vessel tracheal view. See, I'm not getting into how to do these Dopplers, but in normal aortic isthmus will show you a diastolic flow. There would be a continuous forward diastolic flow. If you see that there is a reversal in the aortic isthmus diastolic flow, that is something we say that this aortic isthmus is abnormal. So there's a reversal of diastolic flow in aortic isthmus. And CPR. This has eventually become one of the major entity in fetal Dopplers now. It is something very, very simple. It is a ratio of the MCA PI upon the umbilical artery PI. So nothing too complicated about that. So because normally you will find in hypoxia, the umbilical artery PI will increase, the MCA PI will decrease. So the CPR will reduce. Now again, we used to use a cutoff of 1.08 as a final thing. No, now again we have percentile type. The CPR, the fifth, any CPR less than 5th centile is abnormal. A CPR is going to be different for different gestational ages. So the 5th centile is going to be good. So we always need to go and look into the normograms in there. Now, why CPR has become important? Because the CPR is more sensitive than umbilical artery alone or MCA alone in picking up the suspected cases of FGR, because it is a better predictor of fetal growth restriction and adverse perinatal outcome. Because that it happens. You may have an umbilical artery which is at the higher centile, but still it's near normal. MCA at the lower centile, but near lower normal. But at that stage, the CPR will be less than the 5th centile. The CPR is the one which tells us that there is an issue. And later on, you may find the other changes also coming up. And when you look into Dopplers, also remember the trend of the Doppler is also very important. It's not just about a single reading. Now, if you look at, there are two fetuses I'm showing you, one with the yellow star and one with the red star. Now, in this case, yes, the umbilical artery PI is high, but you look at the trend is the one which is going down. Here it is still within the normal centiles, but the trend is higher up. So which one is the one I'm more worried about? I'm more worried about the red star, not the yellow star. So the trending is also an important issue. So we have a small fetus with primary defect and fetal causes. You have fetal growth restriction. That is what I'm going to talk about is the placental fetal growth restriction. I'm not getting into the other types of fetal growth restriction because of an intrinsic cause. And then you can have a constitutionally small fetus, again less than the 10th centile, but this fetus doesn't have any problem, and that is what we are going to call as SGA. So how do we identify fetal growth restriction? If you exclude the primary defect, you are left with an isolated small fetus. Now, these isolated small fetuses, we need to differentiate them between two groups. Now, in one group, these fetuses may have a poor perinatal outcome. There can be an IUFD. Whereas in the other group, there's a normal perinatal outcome, no IUFD. There are Doppler signs of adaptation in one group. There are no Doppler signs of adaptation there. In group 1, there is a placental insufficiency, which is the cause. Here we don't know the cause. Mostly it is constitutional and others. In this group, we don't want to prolong pregnancy beyond 37 weeks. These are the ones which have abnormal perinatal outcome. In this group, we can prolong pregnancy up to term. This group we call as FGR. This group we label as SGA. And that is where Doppler comes in. That is where we need to differentiate between these two groups. So now, before we get in, because the definitions change, let us see what is early onset versus and late onset FGR. Everything, we've realized over a period of time, it is not just the same. Now, the Delphi consensus actually has come up with one conclusion, that we need to take 32 weeks as a cutoff. So early onset is where it is diagnosed before 32 weeks of gestation, that is early onset FGR. Diagnosed after 32 weeks of gestation, it is late onset FGR. But remember one thing, it's a very, very arbitrary cutoff. There can be an overlap because it is all about, I am doing a scan at 34 weeks, or directly the scan has come to me at 34 weeks, there are problems. It can happen that if the problems must have started much before 32 weeks. So it's an arbitrary cutoff, but it does help us in differentiating between the two subtypes. Now, as per the Delphi consensus, and of course this 2020 we have the ISUOG Practice Guidelines, and they have actually accepted the Delphi consensus. So for diagnosis of an early onset FGR, two things they have kept as a solitary finding, that if it is there, then you have to label it as FGR. If the fetal weight is less than the 3rd centile, or the AC is less than the 3rd centile, forget everything else, we'll put it as, because it is extremely small. Now these are the babies which can be associated with abnormal outcomes, so we put them as FGR. Or if the umbilical artery is showing an absent end diastolic flow, that's again a solitary finding that is sufficient to call it as FGR. Then what are the contributory findings? So we said, a small fetus is less than the 10th centile. So if the fetus is less than the 10th centile, between the 3rd centile and the 10th centile, but if it is present with either a uterine artery PI, which is more than the 95th centile, or an umbilical artery PI, which is more than the 95th centile, we will call it as FGR, early onset. This is the definition for early onset FGR. Whereas for late onset FGR, the solitary finding is a fetal weight less than 3rd centile, and the contributive finding is you have an AC or an fetal weight less than the 10th centile, or you have an AC or fetal weight crossing 2 quartiles. Crossing 2 quartiles means that it has reduced by 50 centile. So if it was at the 75th centile, it has come to the 25th centile. So it has crossed two quartiles. So 1 quartile is 25 centile. So it has crossed 2 quartiles. Even that is one of the, that is something that we will look into it. So any 2 out of this, and you have a uterine artery PI which is greater than the 95th centile, or a CPR less than the 5th centile. So the Barcelona protocol actually had, they had a universal this thing. They actually, more than the umbilical artery early onset, late onset, they've considered CPR as more significant, but the Delphi consensus has used CPR for identification of FGR in the late onset FGR. Okay. Now, let's understand the hemodynamics. Because this actually, if you understand these 2 slides, you will understand why the Doppler changes differ between the two, means how the sequence of event takes place. Now, in early onset FGR, there is a placental disease, which is severe. See, it's always more than 30% of the placenta is abnormal. So there is a severe placental disease, and in majority of the cases, you will find a uterine artery PI which is greater than the 95th centile. Not always, but in most of the cases, you will have that. Now, because there is a severe placental disease, the perfusion is going to be less. Because the perfusion is going to be less, you are going to get a CPR which will become less than the 5th centile. You will have an umbilical artery PI which will increase and become 95th centile. Now this, as it goes, you will have a brain sparing effect where the MCA PI will reduced, become less than the fifth centile. So that is how things are happening because the perfusion is less. And then as things go, when there is a centralization taking place, there is hypoxia, and eventually you will start finding that the umbilical artery has an absent end diastolic flow, the aortic isthmus will become abnormal, and as acidosis sets in or there is advanced hypoxia, you will have a reversal of diastolic flow in the umbilical artery. Now what happens is, now these early onset FGR babies, these are 27 weeks, 28 weeks, 29 weeks. Now, these babies can tolerate hypoxia for a very long period of time. Early onset fetus, IUGR fetuses can tolerate hypoxia for a very long period of time. So what happens is, this time period, is essential for the heart. So this gives the heart some time to work more. So the heart has to work more to pump more blood. So the heart this is what we call as the cardiovascular adaptation that takes place. And once the heart starts working more and more, eventually a stage comes where the heart starts, failing, and then the cardiac is reflected in the form of a abnormality in the ductus venosus. And once there is an abnormality in the ductus venosus, we know the next stage, the CTG will become abnormal, the biophysical profile will become abnormal. So that is what the cascade of events that takes place in early onset FGR. Whereas in late onset FGR, there is a placental disease, but the disease is not much. So the placenta is less than 30% abnormal. So you may have a uterine artery PI which is greater than the 95th centile. But in most of the cases, the umbilical artery is normal. Why? But the CPR falls less than the fifth centile, MCA will go less than the fifth centile. Now, umbilical, we already thought about it, we already talked about it, the perfusion reduced, it says, and then we have hypoxia, and that is why you have a brain sparing effect, and that is why the CPR and the MCA go less than the fifth centile. But what happens in late onset FGR? Because there is a placental disease, it's not very, very severe. So the perfusion is normal. Because the perfusion is normal, the umbilical artery is normal. But even though the perfusion is normal, the diffusion is abnormal. Because there is a placental disease, the diffusion is abnormal, and hence you will eventually get a CPR which is less than the fifth centile, an MCA PI which is less than the fifth centile. You can get an aortic isthmus which is can become abnormal. Now here comes the difference between the two. Like what we saw in early onset, the fetuses can tolerate hypoxia for a very long period of time. But now in late onset, these are 34 weeks fetuses, 35 weeks fetuses. They cannot tolerate hypoxia for a very long period of time. Hence, there is not enough time for the heart to function more in this thing. So it is basically the brainstem which actually is the one. So the centralization is what becomes very, very important here. And that is why the ductus venosus goes out of equation. So you have an MCA PI which is less than fifth centile, you have a CPR which is less than the fifth centile, and you can suddenly have a CTG which becomes abnormal, a biophysical profile which will be abnormal. And so, or then suddenly you may find that there is an intrauterine device there if you don't pick this situation up. And so, because remember one thing, the placenta is responsible for both the nutrition and oxygenation. Fetal smallness is because of intrauterine malnutrition. Fetal compromise is because of respiratory hypoxemia. Now, if you look at this graph, the green is the nutritional need and the red is the respiratory need. And you will see that the nutritional need is a it's a complete logarithmic curve. Whereas the respiratory need, it has an exponential growth towards the third trimester. So as as we enter into the third trimester, later on in pregnancy, it is the oxygen, it is the respiratory need which becomes more important, and hence the hypoxia is the one which becomes significant. Now, because they have already, these late onset sets in later on, the fetus has already achieved a sufficient size. And that is why you may have a situation where the fetal size may not be less than the 10th centile. That is what we will come to at the end. So in early onset placental dysfunction, it affects nutrition and growth more than the respiratory compromise. whereas the late onset placental dysfunction affects the respiratory demands more than the nutritional one, and that is why the size does not become that important. What becomes important is the oxygen which is going to the brain, the hypoxia which is becoming, so all those changes, even in the cardiac, all those CTG and everything that you're seeing is because of the brainstem that is getting involved there. So in late onset FGR, greater than 32 weeks, fetal weight will, yes, of course, we are still taking it as the small SGA is less than 10 centile. You'll have a normal umbilical artery Doppler. You can have a uterine artery abnormality, CPR less than 5th centile, or even in late onset, if you find that the fetal weight is less than the 3rd centile as an absolute value, you have to take it as late onset FGR. Now let us look at early versus late onset. Whatever we have discussed, putting it, early onset is, you see in 30% of FGRs are early onset, 70% are late onset FGR. The problem in early onset is management, whereas the problem in late onset is diagnosis. The problem in early onset is management, because we know these are small fetuses. We are worried about the prematurity. In late onset, yes, they have already attained a particular size. The gestational age is high. Prematurity is not that important an issue. The problem is diagnosis. As I said, we may not go into anything. We may not do Doppler because the fetal weight is not less than the 10th centile. So at 32 weeks, you've done a scan, you may find that it is AGA, but at 36 weeks, it may go and become an SGA there. So that is why the diagnosis is difficult there. The fetus in early onset may be very small. Here it is not necessarily very small. The placental disease is high here, it is low here. Abnormal umbilical artery is high here, it is low here. It is not that the umbilical artery will always be abnormal. Yes, you can get high resistance, but you may not get those reversal of diastolic flow and all those things that is taking place. Preeclampsia, the association with early onset is high. It's nearly 50%. It is 10% here. Hypoxia is more in early onset FGR. It is not much in late onset FGR, but the tolerance to hypoxia is good. In early onset, fetuses can tolerate hypoxia more. Here, the tolerance to hypoxia is poor. So we have early onset less than 32 weeks, late onset greater than 32 weeks. Now we come down to decision making in FGR and management. So we have diagnosed FGR. We have seen what is early onset and late onset. Now, see, there is no point, if you don't know what to do with these things, there's no point doing a Doppler, doing all this. So eventually, what is important is how we put it into decision making. Because the only management for fetal growth restriction is getting the baby out at the right time, neither too premature nor too hypoxic. So that is the only management that we have. So now what all is available with us for hypoxia-acidosis? Yes, we have fetal blood sampling, which we don't do. We have the NST, the CTG, and the computerized CTG. You have the biophysical profile and color Doppler. Now the thing is, the conventional CTG or the NST, yes, is highly sensitive, but it has a very, very high false positive rate. 50% of them is false positive. It is very, very subjective. There's no significant benefit in reducing the perinatal mortality. There is no evidence to support the use of traditional fetal heart rate monitoring or NST. This is coming from international data, because they've all moved on to the computerized CTG. And yes, computerized CTG, which evaluates the short-term variability of fetal heart rate, is sensitive to detect advanced fetal deterioration. It is similar to DUCTUS VENOSUS in short-term prediction of fetal demise. And hence, yes, the computerized CTG is an important entity, but unfortunately, it is not universally available. So, especially, we know that I think there are only 2 or 3 in India. So we may get it, we may start using it when we start. Still the time we don't have it, it's nice to just read about it, but we can't put it into practice with the computerized CTG. Now, about the biophysical profiles, yes, it has a consistent relationship, the score and the fetal pH. Yes, there is a consistent relationship across gestation ages. a score less than 4 is associated with fetal pH less than 7.2. A score which is less than 2 has a sensitivity of 100% for acidemia. But if you go through literature now, if you go through the FGR update coming from Barcelona, and through some meta-analysis that they've talked about, that, as with fetal heart rate, a high false positive rate is there even with biophysical profile, and a meta-analysis showed no significant benefit of with biophysical profile in high risk pregnancies. So if you are monitoring with a Doppler or a computerized CTG, biophysical profile does not really, yes, in late, I'm not saying anything is not important. Everything is important, but yes, it's not meant for diagnosing. It is not, yes, you can use it for surveillance at times, but once you're already doing your surveillance with Doppler, with, a computerized CTG, which is available somewhere else, but as long as those things don't come here, biophysical profile, yes, even yes, in at term also becomes an important entity. NST at term again becomes an important entity. And why is Doppler an excellent modality to monitor fetal well-being? I'm not saying this because I'm a radiologist, so I can do only Doppler and I can't do anything. I can't do the, maybe I suppose I can do biophysical profile also, but I can't do the NST and I can't do the CTG. So it's not because of that, but Doppler is an early indicator of fetal compromise. We've seen this. Doppler, gives you an early indicator. Doppler is based on active performance. There's no, you don't have to sit and wait for the fetus to perform a particular activity. You just directly go to the vessel and do an active performance there. So as far as management is concerned, the ISUOG practice guidelines, actually, which are mainly based on the truffle study, have, the recent guidelines. So they have went to deliver early onset, but there, the protocol is mainly based on DUCTUS venosus and the computerized CTG. So, if it is greater than 26 weeks, if there are spontaneous persistent FHR decelerations, or there is an altered biophysical profile score, you go ahead and do and deliver. Between 26 to 29 weeks or 28 weeks, 6 days, if there is an absent or reverse diastolic flow, A wave in ductus venosus or an SPV less than 2.6 ms, I don't know about that. 30 to 31 plus 6 weeks days, absent or reverse ductus venosus A wave, you can do it. 32 to 34 weeks, it is also permitted after 30 weeks that you have an umbilical artery reverse diastolic flow or an SPV less than 3.5, greater than 34 weeks, permitted even after 32 weeks, because the truffle study had those safety nets, and the safety nets was an umbilical artery, absent diastolic flow and reverse diastolic flow. So reverse diastolic flow at 30 weeks and umbilical artery absent diastolic flow at 32 weeks. And in late onset FGR, of course, if it is at any stage, if there is a spontaneous persistent FHR altered by physical profile, umbilical artery absent end diastolic flow, reverse flow at any stage you need to do. But 36 to 37 weeks plus 36 to 37 plus 6 weeks, if there is a umbilical artery PI which is greater than 95th centile or an estimated fetal weight or AC less than the 3rd centile, you need to deliver. 38 to 39 weeks if there are signs of cerebral redistribution on any other feature of FGR. Now this is coming through the ISUOG guidelines, but then a lot of it is dependent coming on the computerized CTG. But now I'm going to take you through the Barcelona staging. Now that is a stage-based protocol. Now why Barcelona stage-based management? And actually I think I'm a huge fan of that. And whatever success that we from the Society of Fetal Medicine have achieved in the last few years in taking the concepts of fetal growth restriction and management based on Doppler and has been successful mainly because we went with this, the Barcelona stage-based management. Because it's common for early and late onset. They have not differentiated between two. It's a simple algorithmic approach. These are easy to follow protocols. They can be followed by everyone, and the app is available. So there is an app where you just go put in the gestational age, put in the fetal weight, put in the Doppler findings, and it helps you. It tells you whether this is FGR, it is not FGR. It also tells you, do you need to deliver or not. It also tells you when you should do the next Doppler. So it has made life very, very simple. So, and actually practically it is telling the same thing what is coming through the other studies. There is no difference. Only thing is they have formulated into a simple way. Now, stage 1 is a stage of severe smallness or mild placental disease. If you have anything, fetal weight less than the 3rd centile, or a uterine artery Doppler PI more than 95th centile, umbilical artery PI greater than 95th centile, or a CPR less than the 5th centile, or an NCA PI less than the 5th centile is stage 1. Stage 2 is a stage of severe placental disease. If you have either an absent end diastolic flow in umbilical artery or an aortic isthmus reversal. Stage 3 is the stage of early acidosis. You have reversal of end diastolic flow in umbilical artery or a ductus venosus PI greater than 95th centile. Stage 4 is a stage of severe acidosis where you can have a reversal of A wave in ductus venosus and an abnormal computerized CTG. That is what comes from the Barcelona staging. Now, how do you have the staging also? Now, how do you put it into? See, every decision on when to deliver has to be based on, you have to decide where is the risk more? Is the risk of prematurity more, or the risk of continuing the fetus in the uterus is more? So whether the hypoxia is a problem or the prematurity is a problem. Now, the current trends in practice are very, very different. Of course, the very important thing, any deteriorating maternal condition is an indication for delivery. Again, availability of neonatal intensive care is also a very, very important entity in decision making. Personal experience and acquired wisdom. This slide I've taken from Dr. Khurana, and I always use this because he's put very, very practical things. Decision making sometimes does happen because of a planned vacation also, or psychologically. Suppose someone has had an IUD in their practice in the last 6 months, any change in Doppler, they start panicking. And they just want to get that baby out because they've already had an IUD in the last 6 months. That impact remains for a very, very long period of time. Abnormal NST, but no, just an abnormal NST, single sitting is not just an indication. Yes, because as I said, 50% of them can be false positive. Also, any abnormality in Doppler, again, no, there has to be a system. What is the abnormality in Doppler that needs to decide? So what you actually need to do is you need to have a mental fight between prematurity and hypoxia. Which is more dangerous? Now, let me tell you one thing, that the chances every day a fetus spends in utero before 28 weeks, the morbidity reduces by 2%. Every day the fetus spends in utero between 28 to 32 weeks, the morbidity reduces by 1%. So that is something which actually is you always have to have in your mind, because you want the baby to stay in utero as much as possible. At the same time, you don't want the baby to become too hypoxic or acidotic. So what a corollary to that I'm trying to take you through is that, imagine yourself, there is a tall building, you are in the building and the building has caught fire. So now the floor is the gestational age. Higher the floor, lesser is the gestational age. Lower the floor, higher is the gestational age. The fire here is indicating hypoxia or acidosis. And then there is a safety net. Safety net in the sense, like you want to jump. So the fire brigade is there with the net, and that safety net is the NICU. So that also is very, very important. So now you are in the building and the building has caught fire. To jump or not to jump will depend upon two things. It will depend upon what floor you are in and how strong is the fire. How strong is the fire? So once, you take, at every floor that you come in, you have to see how severe is the fire. So for example, you are on the 14th floor. The gestational age is 26 weeks. You know, I'm just putting this. You're on the 14th floor. Now, whether to jump or not to jump is an important issue. But you're on the 14th floor. However severe is the fire, you're not, because if you jump, you're definitely going to die. So there is a fire. You're seeing that there is a fire. You have peeped out of the window and seen that there is a fire. And then you know, but you're on the 14th floor. You know that I'm going to die. The fire has still reached only the 3rd or the 4th floor. So no problem. You start going down. So you start climbing down. So you go from the 14th floor to the 12th floor to the 10th floor, and then go and check again from the window where has the fire reached. So you've gone to the 12th floor and you have realized that the fire has come to the 7th floor. Again, if you jump from the 12th floor, you're still going to die. So what is, because however is the issue, and the fire is still only up to the 7th floor. So you still go down. So you go to the 10th floor, and when you go to the 10th floor, you find that the fire has actually reached the 9th floor. The fire is severe. And once you have come there, now, if you jump, there's still an issue. But if you don't jump, anyway, you're going to be burned. So the better chance that you have is that you need to jump. There is already a fire brigade there. There is a good NICU. And the only chance that you have of a survival, yes, you may have problems. You may have a few burns here and there, but you still have a chance of surviving. And so once you reach there, you're going to jump. But suppose you are on the 3rd floor, you're at 37 weeks. You're on the 2nd floor or the 3rd floor. And even there is a small fire, very, very small fire. Are you still going to wait? Are you going to think that, no, we don't know how rapidly this fire may come up. There is a fire already there, but you know that if I jump, I'm not going to have too much of a problem because there is a safety net. Maybe, I may have a little bit here and there, but I'm going to survive and I'm going to survive well. And then you will take a call and you'll jump. So if you're already at 37, 38 weeks, you've reached 37 weeks, even if there is a small issue, even if there are Doppler changes, even if it is stage 1, why do you want to wait? So, let me tell you one story. There was this guy who wanted to hire a driver. He called all the drivers and he said, there is, on this road, at the end of this road, there is a valley. I want to see who will go closest to the valley and stop the car. So 3-4 people, they tried. Somebody stopped it at 1 feet away. Somebody stopped it at 2 feet away. But the one driver said, if I know there is a valley there, I won't even try to reach up to the 1 feet from there. Why should I go all the way there and try to stop my car? I will stop it much earlier, or I will take some turn from there. And that is why it becomes very, very essential, So that driver was hired because he was sensible enough. So if you're already reaching, you know there is a valley there, you're already reached an optimum distance there. Why should you wait further? Why should you go all the way to the edge of the valley there? Okay, yeah. But if I'm at 28 weeks, if I'm at 29 weeks, I will wait for the fire to come closer because I know even from there, if I jump, I'm going to land up with a problem. And if the fire is not severe enough, I can still wait. I can still go 1 floor down. So if there is an FGR which is greater than 37 weeks, any stage deliver. This is what the Barcelona protocol says. If it is greater than 34 weeks, stage 2, 3, 4 deliver. Stage 1 do weekly monitoring. If it is 30 to 34 weeks, stage 3, 4 still deliver. Stage 2 twice weekly monitoring. Stage 1 weekly monitoring. If it is between 26 to 30 weeks, stage 4 deliver. Stage 1 weekly monitoring. Stage 2 twice weekly monitoring. Stage 3 daily monitoring. Now this is what the Barcelona protocol, everything put together. So the stage 1 gestational age of delivery is 37 weeks. Otherwise you need to monitor weekly. Stage 2 gestational age of delivery 34 weeks. Monitoring bi-weekly. Stage 3 30 weeks. Monitoring every 1 to 2 days. Stage 4 26 weeks. monitor twice a day if you want to still go further. That is what the Barcelona protocol says. At times it may not be very easy to put that into practice, especially because we don't have centers which are equipped with a Doppler and everything where you do it twice a day. There could be practical difficulties, but this is what the Barcelona protocol talks about. And this is the complete chart. This is the complete chart of the Barcelona thing. They have the stages. They have given the criteria, what all comes under what stage, how should be the monitoring, what should be the gestation age at delivery, and what should be the mode of this thing. If you can follow that, it really is going to become very important. It's very important. See, if there are two groups of people, there is one group of people who have have an absolute good understanding about every aspect of Doppler, everything, the perfusion, diffusion, they understand everything, but they don't follow protocols. And there is another group, they don't understand too much about the hemodynamics, but they say, okay, this is the protocol, I will use this protocol in every case. The overall success rate in the one which follows protocol is always going to be much higher. These brilliant people who understand everything but do not follow protocols, they may in one or two cases may do exceptionally well, but overall their results may not be very good. And that is why we need to, that is why I say that Barcelona staging, the Barcelona protocols become very effective. And now we look at FGR, which is AGA. Not going to, because it is one of the most controversial thing at the moment. There are studies which come supporting, talking about it. There are studies which, there is not enough evidence to say that an AGA fetus, there is evidence that an AGA fetus can be fetal growth restricted. There is evidence that they do have abnormal outcome, but how to manage them, what should be the surveillance, it's still controversial. So we will see this. Now look at this chart. This has come from the Netherlands. If you look at this, you will realize that, of course, the highest perinatal mortality was when the fetal weight was less than the 3rd centile. The lowest was when it was between the 90th and the 95th centile. But even at other stages, because see, if I look at the 10th centile, anything between the 10th and the 50th, there is still a significant amount of mortality that is taking place there. And at least 50% of this are because of fetal growth restriction. And that is the reason the 10th centile cutoff is not an absolute value. It is not a final word. You can have this. So, but we saw that if it is an AGA, you have more than 10 centile, but it is crossing 2 quartiles down. It is going from a higher normal to a lower normal. Like if it's going from the 75th to 25th centile, and there are Doppler changes, we diagnose and manage it as per the late onset FGR that has already come into the protocols also. But if it's an AGA where we don't know about the velocity, how much should we see? The problem is, as I said, a patient comes to me at 36 weeks or AGA, but the other scans all have been done with different people following different charts, different this thing. It is very difficult for me to see how the velocity has been. I'm not very confident whether the biometry has also been taken well or not. So an AGA fetus at 32 weeks may become SGA at 36 weeks. So 32 weeks, the fetal weight may have not gone because the placental disease is not severe. As I said, the nutritional, it has already achieved a sufficient size. It may not be less than the 10th centile. But if you do a scan at 36 weeks or 37 weeks, you find that it is, and that is why, these are the ones which need to be, we need to be very careful about. We also need to look into this AGA aspect. So if the fetal weight is between the 10th and the 50th centile, okay, if it's more than 50th centile, we will not really bother too much about it. But if it is between 10th and the 50th centile. So practically speaking, that is why I am saying that all growth scans in the 3rd trimester should be associated with Doppler. There will be a lot of contradictions coming on that. There are studies which have said no, a Doppler, in an AGA fetus actually leads to an unnecessary intervention at an early stage. There are protocols, those studies also have their own limitations. But you can't have, you need to avoid those IUDs, you need to avoid those the stillbirths. It's very difficult for us. Practically, patient is coming to So patient is coming to me at 32 weeks, it is AGA, I don't do anything. Patient comes to me at 36 weeks, I still find it is AGA, I don't do Doppler. And I say, okay, fine, everything is okay. And this lands up as a stillbirth at 39 weeks. Patient will say that I've been coming to you every time. I have been following up regularly, but you've not been able to, how come this baby has died? So we need to do all growth scans in third trimester need to be associated with Doppler. So we need to do a 32 weeks and a 36, 37 weeks if we want to pick up all these late onset FGRs. Even the SGA late onset and the AGA late onset. We need to have Doppler scan at 32 weeks and 36, 37 weeks. And so if you have fetal weight less than the 10 to 50th centile, and if you have a CPR which is less than the 5th centile, these are the ones you need to have a very, very strict surveillance and follow-up. If they've crossed 37 weeks, 38 weeks, yes, deliver them. Because these are the ones which are associated with abnormal outcome. A dipping CPR, so you have a CPR which is less than the 5th centile. You are following that up. You're going to tell the patient to look for fetal movements more. If there are reduced fetal movements, if there is an abnormal CTG, or if there is a dipping CPR, if the CPR is dipping down, we need to get these babies out. And that is what comes up. So in a nutshell, in FGR, identify a small fetus, that's the first thing. So your dating becomes important. Do Doppler, distinguish between FGR and constitutionally small fetuses, stage the FGR and plan surveillance, and then you decide on when to deliver based on all these things that we have discussed so far. So the most important message is, the most important thing is to identify FGR, and for that, first and foremost, we need to assign the gestational age properly and start using growth charts. Early and late onset FGR represent distinct phenotypes of the same disease. Smallness in size is a predominant characteristics of early onset preterm FGR. It may not be a factor in late onset FGR, and 40% of late pregnancy IUFD is because of late onset FGR, and we have to start accepting this fact, live up to it, and start monitoring it and start identifying it. An objective protocol-based approach is now validated. It has been successful. We've been using it in India, and it is coming up very, very well. I will put this question to our experts in the panel discussion also and know what they feel. I personally feel that this is something which is, we need to get into this. DUCTUS VENOSUS evaluation is the cornerstone of assessing when to deliver in early onset FGR. The CPR is the critical index in late onset FGR. Scans at 35 to 37 weeks and 28 to 32 weeks are becoming increasingly justified even in the low risk groups. And I end with an appeal by the fetus. This is a poem written by unknown resident in Dublin way back, long back when we didn't even have too much of this concept. And this poem is that I've not written it, sorry. I am a fetus in the womb. I fear it may become my tomb. If only I could give a shout to make my doctor get me out at the right time, neither too premature nor too hypoxic. And with this, I end my talk, and just keep calm and follow protocols. That's the message I give, and thank you very much.
Thank you, Dr. Bimal, sir. That was a marvelous talk. And I think this is the 4th time that I've listened to you talk on FGR, and every time I'm mesmerized and always learning something new. Thank you so much. We had some initial technical glitches with Dr. Shyam Baruah sir's talk, but now I think he's ready. So now we'll have the talk by Dr. Shyam Baruah sir, and he shall be sharing his experience on scanning beyond the 3-vessel tracheal view of the fetal heart. Over to you, sir.
Right. Good evening. I hope you can hear me.
Yes, we can, sir. But you have to share your screen.
Good evening, everybody. I will start with my talk straight away. And thank you very much, Dr. Bimal, for your very detailed talk on IGR. I would like to talk beyond three vessel view. It's a fairly simple talk and easy to express, but it's difficult to do. And this has been an optional area to scan, even according to the guidelines. But if we revisit this area and if we scan this area, which is difficult because of the rotational movements in the cervicodorsal area, the fetal mandible and shoulder. But if we make it a habit to see it routinely in normal pregnancies, then it is very color Doppler for the complete diagnosis. So to see the following structure, which is often not seen routinely, the fetal clavicle, the thymus, the brachiocephalic vein, and the subclavian artery. So as you can see here, this is a transverse section of the fetal clavicle, and the medial 1/3 is convex, it is thicker, and the lateral 2/3 is concave, giving a mild S-shaped and the clavicle ossification et al. Back in 1985 established a simple relation of estimating gestational age in weeks as roughly equal to the length of clavicle expressed in millimeter. However, subsequent papers have said that such estimation of gestational age by clavicular length can overestimate the age by 6 weeks. And what is important is what is more important is the absence of hyperplasia of the clavicle in conditions of skeletal dysplasia with fetal narrow. So we use 3D evaluation of the clavicle with usually in the dorsal anterior both the clavicles, and in addition to that, ribs. So overall, it is helpful to do 3D first. Coming to the only congenital abnormality of clavicle which we see is the absence of clavicle. And clavicle forms the anterior, the shoulder. Short stature. Then you have Gott's syndrome and Child syndrome. These are, of course, diagnosable only after birth. It's a dermatological condition with
We do have an interruption here with the connectivity from Dr. Shyam Baruah's office, and we're trying to work that out. Shyam, we've lost your screen and we've lost your audio as well.
Yes. Been very unlucky actually today.
Yes, it's.
Sir, I think you can try connecting with your hotspot, mobile hotspot maybe, or something.
Until
Yeah, that sounds like a great idea. Yeah. We do hope for better connectivity in a few minutes. It's really nice to see participants from all over the country here as attendees. Today we have people from Kerala, we have people from Gujarat, Maharashtra. I see some people who were on last night and are on today. We see stalwarts like Dr. Kamal Oswal, Dr. Kanchan Mukherjee. We see my good friend Manohar from Tamil Nadu. We have Jitendra Sahu from Nagpur, and I notice also that we have a lot of people from the north. We have Beena Mishra, we have of course Dr. Maninder from Faridabad. And it's nice to see everybody here, and we also have people from Sholapur, for instance, Dr. Milind Shah, who's got this phenomenal reputation for perinatology, is here with us today, and of course our youngsters. Jimit Patrawala as well as Nikhil Joshi. It's so nice to see you all here. We have professors such as Deepa Goyal here with us today. We have Neelam Sodhi from Ludhiana, who's our leader there. And I'm so glad we could all join in today and be discussing all of this, because we had the international flavor last night and today we have this. There's been a lot of questions on the possibilities of what we will be doing. For those who have missed a part of the webinar when it started for our quarterly meeting. And what we're doing is that we're putting a lot of these quarterly meetings onto our SFM YouTube channel. So the SFM YouTube channel will have edited portions of these meetings that everyone can have access to. And there we are, we're back on the screen again. So we will gossip again later. Let's wait for the presentation to start from where we left off.
hello.
Yes, all clear.
So we talked about cleidocranial dysplasia. Then we said that Gott's and Child syndrome are only diagnosable after birth, and it's a dermatological condition with upper limb abnormalities. We have the Holt-Oram syndrome, which is also known as the atriodigital syndrome, where you have a ASD, conduction defect, radial aplasia, and sometimes clavicle hypoplasia. Then a very, very rare condition, Melnick-Needle syndrome, which is a primary osteodysplasia. And you have a typical feces of face appearance of exophthalmos, micrognathia, malalignment of teeth. You have metaphyseous flaring, bowed long bones. You have Eunice-Varun syndrome, which is a variant of cleidocranial dysplasia, and this consists of cleidocranial dysplasia with micrognathia and absent thumb. Then you have the cerebrocostomandibular syndrome, where the mandible condylar process is absent. Fetal varicella infection, and very rare condition of Marden-Walker syndrome, which you have radioulnar synostosis, you have kyphoscoliosis, you have joint contractures, and associated with Dandy-Walker and agenesis of corpus callosum. Coming to the thymus, as you can see, thymus is located in the anterior mediastinum, and it is between the sternum and the great vessel. It is surrounded by fascia, and the gland is more hypoechoic and well defined from the surrounding lung in the second trimester and third trimester. But in the first trimester, the thymus is ill-defined. So it was Palladini who first introduced the thyo box to better delineate the lateral thymic margin from 16 weeks gestation And the lateral thymic artery, you can see, is outlined by the internal mammary artery arising from the first part of subclavian. And in the second trimester, the thigh box is bigger, and you can appreciate the internal mammary vein along the lateral border of the thymus, draining into the brachiocephalic vein along the posterior border of the thymus. Now, in the thymus, they're primarily concerned with the size of the thymus, and the accepted way is TT ratio, which is independent of gestational age. And if T1, TT ratio means T1 by T2, and if T1 is the distance from the sternum to the aorta, and T2 is the distance from the sternum to the anterior spine, then the ratio of T1 to T2 in studies from 2011 have revealed the ratio to be more than 0.44. They also found that in fetus with CHD with microdeletion 22q11, the ratio was significantly smaller in 90% cases, below 0.3 with a mean of 0.25. Interestingly, they did not find any significant difference in TT ratio between the groups of CHD with normal karyotype and a normal population. This is an illustration of tetralogy of Fallot with normal TT ratio, and the second one, a tetralogy of Fallot with abnormal TT ratio, suggesting that this could be a microdeletion 22q11. Aplasia or hyperplasia of thymus is relatively uncommon, but it's very important that there's high association of chromosomal anomaly, especially for microdeletion 22q11 and trisomy 21. The risk of non-chromosomal syndromes is low. So when the thymus is absent, the great vessels appear to displace anterior behind the sternum. Coming to the left brachiocephalic vein, it's a large vein that runs from left to the right, joining its counterpart and forming the SVC. But what we must remember here, that the vein is just immediately superior to the aortic arch, almost adjacent, and just posterior to the brachiocephalic vein are the neck vessels. Since the midline, posterior to it is the trachea. So the left brachiocephalic vein is formed from the anastomosing transverse vein between the two anterior cardinal veins with regression of the left anterior cardinal vein. Failure of formation of this transverse vein results in the persistence of the left anterior cardinal vein as persistent left SVC. So we can see here the brachiocephalic vein along the posterior border of the thymus, and posterior to the brachiocephalic vein you have the brachiocephalic artery, the left common carotid, and the subclavian, and at a distance away you have the fluid-filled trachea. So here's this. We're showing the brachiocephalic artery here, and we can see there's a measurement we take, and the brachiocephalic from 12-week onwards measures 0.7 millimeters to 4.5 millimeters at term. And we noticed, first thing we noticed is the fluid-filled trachea posteriorly and the neck vessels posterior to that. And sometimes the brachiocephalic vein has an intrathymic course, which is the normal variant. But more often than not, if the brachiocephalic vein is absent, then we have a left-sided SVC. And sometimes when we have a left-sided SVC, if the right-sided SVC is absent, then the vein that we see is the right brachiocephalic vein. Now, the brachiocephalic vein can be enlarged in two conditions mainly. One is supracardiac TAPVC, and second is due to increased flow from high flow states in the CNS, such as the vein of Gallant malformation and the AVM of dural sinus. So here we can see the brachiocephalic vein along the posterior border of the thymus. Please notice the fluid-filled trachea and the esophagus adjacent to it, and these are the vessels to the neck. Similarly here, you can see the brachiocephalic vein, and this is a transverse section at the level of the medial limb of clavicle. And if you give a caudal angulation, you see an overlap with the transverse aortic arch, and posterior to that, you see the fluid-filled trachea dividing into the right bronchus and the esophagus. So the subclavian arteries, as we all know, the right subclavian artery arises from the brachiocephalic artery and the left subclavian artery arises directly from the aorta. So we have an entity called aberrant right subclavian artery, which is also known as ARSA. And if you notice that it arises much posterior than the normal subclavian, posterior below the aortic isthmus, and goes posteriorly behind the trachea and esophagus to the right shoulder. Now, this section, after seeing normal patients, many normal patients, we see the subclavian artery. And if you notice, both the subclavian arteries, they arise from the transverse aortic arch, and they have bicycle handle appearance. There's an overlapping with subclavian vein at the axilla. And when so my point being is, if we look at every case, if you look at the origin of the normal subclavian artery, which is anterior to the trachea, this finding acts as a protective marker for trisomy 21. Protective because suppose we don't see the normal origin of the subclavian artery, then we can especially look for this very difficult vessel called ARSA. And as you can see, with the constant movement, it just appears in flash. It appears at lower down from the isthmus, going posterior to the trachea and esophagus. So I just want to, one is to be careful not to confuse the azygos vein with ARSA. And these are two different patients, and you can see the azygos vein going posterior to the esophagus and trachea and entering the superior vena cava. You can see the same here with the azygos vein trachea entering the azygos vein. The importance of ARSA came with the meta-analysis of second trimester markings for trisomy 21. And there was this finding where they found ARSA. If you had ARSA, it increased the risk of trisomy 21 times. If you had isolated ARSA, it is the risk of trisomy 21 4 times. So, incidence of ARSA in normal population is 1.4%. It varies in many studies from 0.9 to 1.4. But the most important thing here is that all ARSA detected, 20 to 25% is trisomy 21. And if CHD is associated with ARSA, then the possibility of 22q11 microdeletion is there. And as you can see in this diagram, this picture static image, you can see the ARSA arising from the left side of the isthmus and going posterior to the trachea and esophagus. And sometimes it can cause dysphagia lusoria and manifest postnatally. So finding of ARSA in a low risk population should, according to Chanan et al. In ISUOG 2018, should have a detailed fetal echo. They should be offered invasive testing of chromosomal microarray, and also postnatal follow-up is required. So if we recap the transverse examination of the cardiovascular system, we started with the 4-chamber view. And then the next cranial plane is the 4-chamber view going into the short axis view. And then we have discussed 3-vessel view many times. And if you give a caudal cranial angulation, you begin to see the origin of the subclavian artery. And then from the first part of the subclavian artery, you see the internal mammary artery. So then we showed subclavian artery at first trimester, and I said if we could routinely screen subclavian artery in the first trimester anterior to the trachea, it is a protective marker for trisomy 21 because we are ruling out ARSA. Then we showed second trimester looking at bicycle appearance. Then we demonstrated the thigh box in first trimester between 13 to 16 weeks to see the size of the thymus. And we demonstrated the brachiocephalic, left brachiocephalic vein. And I want to stress here, posterior to the left brachiocephalic vein, you see the trachea very well, bifurcating into bronchus, main bronchus, and together with this, the esophagus. And I would suggest that this is a good section to assess size of trachea and esophagus in esophageal nutrition. And finally, so conclusion of the talk being is this: if we can routinely see for subclavian, normal subclavian artery, it is a protective marker against trisomy 21. Because why? Suppose we don't see this normal origin, then we can take special effort to see ARSA. And the brachiocephalic vein section is a useful section to see the caliber of the trachea and esophagus in esophageal nutrition. Thank you.
Thank you, Dr. Shyam Baruah, sir, for an excellent and very informative talk. I'm sure it's going to encourage many of us to start pushing our boundaries and scan beyond the three-vessel view and look for the structures that you have so wonderfully demonstrated. I think now we can go on to our panel discussion. So, Bimal,
Yes,
sir.
and if I take a minute before the panel discussion, yes, a word of appreciation for our supporters from the industry. It's nice that they partner with us to help us meet our costs for education, which is how we're able to bring you these at a free of cost situation. These are messages from our trade supporters for this program, and my thanks to them for this support.
Let's stop sharing.
Thank
So
you.
now we...
Now to the panel, yes, please.
Yeah, okay, so thank you. Next, we have a case-based panel discussion. The topic is FGR, when to deliver, and decision-making. This discussion will be moderated by Dr. Bimal Sahani, sir. And I would like to take this opportunity to invite and introduce our 5 panelists for this talk. We have Shyam Baruah, sir, who has already mesmerized us with his excellent talk. Then we have Dr. Shashwati Sanyal Chaudhary. She is the Associate Professor of Guwahati Medical College, Department of Obs and Gynae. And she's also the Vice President of ISOPARB and the President of ISOPARB Assam chapter. Then we have Dr. Apurva Kumar Bhattacharya. He's the Associate Professor, Department of Obs and Gynae in Jorhat Medical College. He is the Vice President of our SFM Assam chapter, and he has got many papers and presentations in his name and is a regularly invited faculty to many regional, national, and international conferences. I would like to welcome Dr. Nilakshi Fukan Kumar. She is a very renowned obstetrician and gynecologist in Guwahati. And she is the director of Gynex Center, consultant in Downtown Hospital, and she is the president of the Menopause Society. Lastly, I would like to welcome Dr. Ruby Buragohai. She is a consultant radiologist at Ecopath Center, and she has vast experience in ultrasound, especially in fetal medicine being her main interest. And he also is quite regularly invited faculty in our regional conferences out here. So over to Dr. Bimal Sahani, sir.
And of course, we have an expert sitting for all the cases.
Yes, that's the icing on the cake. Yeah.
So wherever, because you know,
Khurana sir will be giving his expert opinions after all the cases and then consolidating all the messages and take home points that is going to be discussed.
Yeah.
Thank you, sir.
Now, before I actually get into the cases, I was just going through the questions that have come up, and thank you, Khurana sir. You've already answered quite a few of them directly there. And but one question which was, which was very persistently seen was what growth chart to follow. A lot of people have this controversy more because a lot of them are following the Indian population charts, and then the machine gives the headlock. So, we have, I just put in 2 slides here before coming, because this is one question which is, in fact, since today morning on my WhatsApp, there were about 37 questions sent to me by people who know me, and 17 out of that, the question was which chart to follow. Because eventually we are saying that it should be 10 centile of which chart, but because see, we have local population charts in India, like Mediscan and the Prashant Acharya's chart. Then we have Hadlock, then the new kid on the block is the intergrowth chart, which actually has come from the Melinda Gates Foundation, and they've done some work and come up. Then we have the WHO chart and other charts, the growth charts, and then the customized charts, which is actually, again, something which everybody wants to talk about. Now, just let me tell you what is actually the difference between these charts. So see, there are 3 types of charts. One is the population reference chart. So you have the reference charts and you have the standard charts. Now, in reference charts, what has been done is they have included the biometry and weight of all the pregnant women. Out of that, there were fetuses with abnormalities, there were fetuses which were SGA, there were fetuses which were LGA. Everything is put up, and then you get a reference chart. Whereas a standard chart is something where what you do is you take only those fetuses into consideration who are born to mothers who are well fed, coming, there is no nutritional problems with them. They are not having any, preeclampsia or hypertensive disease. They don't have, there's no genetic issue involved. So absolutely standard, well-fed, and optimal sized women, and this standard charts are made out of that. And then the customized growth chart, which has come up recently, also takes into consideration the ethnic origin, the height of the mother, the sex of the fetus, the male, female, and everything. Now, customized growth charts, actually speaking, there is a lot of controversy regarding that, and it has been found that it really does not work. Like actually, a wonderful thing which Sir said yesterday, Khurana Sir, in yesterday night's panel discussion was that in India there is so much of migration, and there is so much of somebody from the northeast is migrated to Maharashtra and married to a Maharashtrian, a Gujarati is married to a Punjabi. So there is nothing like ethnicity left there. So we are left with these 2 reference charts. Now remember one thing, that if you use a population reference chart, then you are going to underdiagnose the small for fetal growth restricted, the small fetuses. Whereas if you use the standard chart, you may overdiagnose. But then in our country, with so much of fetal growth restriction, we need to pick them up, and that is why we can come to one conclusion, that we need to have a standard chart. So whatever standard, you can use intergrowth, you can use Hadlock, but as of because we are so used to Hadlock, and Hadlock actually is quite very, very close to intergrowth. So that is something that we can, that is something that we need to use. I will ask our expert right on the beginning, Dr. Khurana. I want you to answer this issue. I also want to ask you, I made a very, very broad statement during my talk that we still stick to the Barcelona staging. So was I right in saying that? And again, when I'm talking about the charts, do you have any other views on that?
Thank you, Bimal, and thank you for that absolutely fabulous talk that you gave us. As I was mentioning in the chat box, it was truly an international recipe by our local master chef. And you have put things so brilliantly into perspective, because we need means by which we can communicate the problems of the fetus to the treating obstetrician. And the only way we can do that at different levels of expertise is the Barcelona charts. There is too much of a mystery and subjectivity in a lot of the guidelines. And if you notice the ISUOG guidelines that have come out last month, they very clearly say that we need to adapt those guidelines for our local observations and for our local problems. And I would fully agree with you that the charts to be used in daily practice today all over our country and developing countries is the Barcelona algorithms and protocols.
And as far as the growth charts?
As far as the growth charts are concerned, you are absolutely correct. We cannot just lump the deliveries that were happening at 32 weeks because of iatrogenic prematurity, for instance, because the mother was hypertensive or the baby was severely growth restricted. We must have a standard population chart, and Hadlock serves as a fabulous one. I like to use Intergrowth just for fun sometimes, and they correlate so beautifully. There's a lot of criticism on this practice. There's a lot of controversy, but I find that the Hadlock chart identifies exactly those babies that are going to misbehave in the perinatal period, and that's the population we're looking for. So we will always use a standard population chart as of the 20th of September 2020.
Thank you very much, sir. So now I move to the panel. I have an excellent panel with 3 obstetricians and 2 radiologists in this panel. And this is complete expertise that has been given to me for this panel discussion. So I know one thing, that at the end of this thing, I think all the questions that have come up on this thing would be answered by my panelists only. I won't have to sit back and delay my dinner much, because everything would be over by the time this panel discussion is over. So there are 6 cases. We will, I would want each panelist to take one. And of course, the other panelists, wherever they feel there is a difference of opinion, then they can just come in and give their opinion on that. Because see, growth is something, there is definitely going to be some controversies. There is definitely going to be some debate on that. And that is welcome, because it is, the topic itself is such. So first case to, Dr. Shyam Baruah, if you would take this. There is a 28 years primary for a scan at 30 weeks. She's come to us at 30 weeks. Fundal height is 26 to 28 weeks, healthy, gained 7 kg since early pregnancy, BP is absolutely normal. And now this is how the, the growth is, because the dating, you can see that the BPT is 48th centile, HC 49th centile, the AC is at the 10th centile, the femur length is at the 10th centile, estimated fetal weight is at the 14th centile. So now my question to you is this FGR? Sir, you have to unmute yourself.
Yes, I would like to follow it up for FGR, but would like to see the Doppler findings first.
Okay. So do you need more information? Primarily, more. Yeah. And I think the first and most important would be also to look at the previous scans. So, but yes, in this case, the 8-week scan was corresponding. The NT scan was 12 weeks, 3 days. That was also corresponding. The uterine artery PI was normal. And anomaly scan 20 weeks was also corresponding. No structural anomalies. Everything else was normal. And when you look at, I'm showing you the Doppler here. There, of course, the umbilical artery, MCA normal. CPR is at the 5th centile.
5th percentile, yes.
So we have an estimated fetal weight at the 14th centile. CPR at the 5th centile. Is this FGR?
Well, this is FGR. This is placental insufficiency and FGR. It's either or. This is stage 1 Barcelona.
Either or, because the CPR is still at the 5th centile. It has not got less than the 5th centile. So would you definitely, you'd like to follow it up, and when would you like?
We could.
When would you like to?
I would like to follow it up on
because it's still not SGA. Is the CPR is at the 5th centile? When would you like to follow it up, sir?
I would like to follow it up after 4 weeks. Or what is it?
4 weeks would go too far away.
At 32 weeks. Yeah. At least at 34 to 36 weeks.
Yeah. And so 32 weeks. So after 2 weeks, we call the patient after 2 weeks. And now the
After 2
AC,
weeks, yes.
yeah, the AC has come to the 8th centile, and the fetal weight is now at the 10th centile,
Yes.
right? And you have the CPR still at the 5th centile, and umbilical artery NCA are still normal. So now will you, because in the previous this thing, by definition, it was still not fitting into FGR, but now would you like to call it as FGR?
Yes, I would like to, because there's a reduction in the centile where AC is concerned.
Yeah, it has come down to less than 10 centile, but fetal weight is, but still the Dopplers are still normal.
Still
And yeah, so this is borderline. This is checking somewhere in borderline. So I can't just leave it aside. You know, just saying that, okay, no, because the fetal weight is still at the 10th centile, it has not gone less than the 10th centile. So now rather than, because if it is stage 1 FGR, we would like to do it after 1 week. But here,
yes.
because this is still borderline, we call the patient after 2 weeks. And now the AC is at the 4th centile, and the estimated fetal weight now has gone less than the 10th centile. It is at the 4th centile. Umbilical artery is showing high resistance, more than 95th centile. The CPR has gone to the 3rd centile. So
Yes.
now is this FGR?
Yes, it is.
This is definitely FGR. And so what next? Follow it up,
So
or would you?
we follow it up. We follow it up weekly.
Yeah, weekly, because our Barcelona protocol says that if it is stage 1, now this is stage 1. What stage? This is stage 1. So we will follow it
Stage
up
1.
after
Yeah.
1 week. So
1 week.
now this, again, I've got the staging and everything in front of it. So stage 1, we need to do a weekly monitoring. So now this is 35 weeks. The AC is gone to the 2nd centile. The fetal weight has gone less than the 3rd centile. Umbilical artery is high, 90th centile. NCA 6th centile. The CPR now is at the 1st centile.
Yes.
So what stage is this now?
So we're still at stage 1.
We are still at stage 1. So will you deliver now? Would you suggest delivery now?
No, I can follow it up till 37 weeks. Continue.
Yeah. So we
Yes,
follow
I can
it
still
after.
follow it up.
Yeah. So after 1 week, that is at 36 weeks, fetal weight at the 1st centile. No, that is always, it has been there right from the beginning. Now, umbilical artery is still high. There is no absent diastolic flow. NCA is at the 3rd centile. CPR is 1.01. So this is definitely still stage 1. And as you said, you would still like to wait. So, so we move to the next scan, and we are following the protocol systematically. 37 weeks now.
Yes.
Weight is at the 1st centile. The CPR has still gone down. Now, this is still stage 1.
This
But
is stage 1.
will you deliver?
Yes, I would deliver, because it's 37 weeks now, and I would like to induce labor at this stage.
Yes. So that is the mode of delivery, is going to be induction of labor. Things are there. And so stage 1, so that is what the Barcelona staging talks about, that we need to, if it is stage 1, we need to keep doing it weekly, and the gestation age of delivery is at 37 weeks. So what lesson that we have learned from this is that iatrogenic prematurity can be avoided or minimized by an evidence-based algorithmic approach and clinical surveillance. So we have gone, see, if we would have just gone ahead and delivered because the Doppler is showing some problem, we would have erred towards prematurity. But because we were following a systematic approach based on a protocol, we take this fetus up to 37 weeks, thereby preventing prematurity, and also at the same time not letting the fetus become too hypoxic. So can we have our expert opinion on this?
Yes, I just want to say something regarding the induction of labor.
Yes, ma'am.
Yes. Yeah. So because this patient, this baby is a little because of this AC is lesser. So whether it will be able to tolerate that induction method. So the induction method, I would prefer not to use those medicines which will cause strong uterine contractions. Say, for example, prostaglandins, misoprostols. So in these cases, I'll do something which is, and I also need to do a close monitoring. Ideally, it should be electronic fetal heart monitoring, ideally. Because sometimes, you know, they're very, very treacherous at some point of time. They may, suddenly there may be problem at the time of labor. How they are going to behave during labor, we don't know. So you have to be very careful, and they have to be delivered in a level, 3 care. That's my comment.
Thank you, madam. That's a perspective coming from a clinician that was really, really required. We as imaging people, for us, for us, the story ends that yes, and that is a very, very important point that you have made. So, Khurana sir, any opinions on this case now? So you have to unmute yourself, sir.
Sorry, that was an excellent comment from Dr. Sashpathy, that the usual method for surveillance, for monitoring during labor is intermittent auscultation, and we know that that is completely inappropriate for this situation. This is not a routine risk pregnancy. This is a high risk pregnancy, and therefore we have to respect it accordingly. And electronic monitoring with a clinician sitting there, because we cannot trust our team completely. There could be one member of the team that can destroy this effort we've made. We've minimized iatrogenic prematurity. We realized that we've reached term, nevertheless early term, but we know that 37 weeks is wonderful. And therefore, this is an excellent way to go about postponing and preventing iatrogenic prematurity, which you know contributes to about almost 40 to 50% of the prematurity we see today. So that is the one lesson learned. The one input I want to give in response to a question was that, are we doing growth scans every week, or are we doing just a Doppler every week? In practice, I must confess that our patients feel nicer with the figure of exactly how many grams is this baby begun, and have I put on those 57 or 58 grams that I was expected to put on. Truly speaking, there is no logic, scientific logic, to repeating the growth unless 2 weeks have gone by. But we do, in this situation, yield to the psychology of the nation and say we will do it for that particular reason. It's important for us to be not just treatment individuals, but healers as well. And healing starts here. So I compromise on science, and I do do this. But I must confess that I keep my previous readings very, very available and make sure that my abdominal circumference has not fallen from 189 millimeters to 187 millimeters, because then there is panic all over the nation. And so for that, it's very important to make sure, because the patient's eyes are right there. And we're treating psychology, we're not treating science here. So do be careful when you do that. And I think it is a very, very nice question that somebody asked in such a subtle manner, that, okay, we are doing it. Scientifically, we do it every 2 weeks, but in our reports, we do it every week. There was one more question which I think we need to answer at this point, and that is that we are in a transition phase from centiles to conventional reports. And we know that reports coming in from Europe and the United Kingdom insist on talking about a centile report and a brief one-line conclusion on when to revise. Traditionally, obstetricians, many obstetricians and most obstetricians in the North do believe that they have a better concept of, if my baby is 37 weeks and I'm getting a size of 34 weeks, they're able to appreciate that much better. And therefore, what I do in my reports is I do the entire centile reporting, but I also add that the fetal maturity is 37 weeks, and that I've calculated from my dating scan, that the fetal size corresponds to 34 weeks, or that cranial parameters correspond to 35 weeks, and the abdominal circumference and female length correspond to 33 weeks, etc., etc., and then the fetal size. So depending on the kind of people you are handling in terms of the obstetrician's understanding, the idea is not to give one fancy international report. The idea is to communicate the result. It is perhaps wise, as Dr. Neelam asked us, to actually mention both aspects of the report. That means the full mathematics as well as this. And the third thing, before we move on to the next case, Bimal, is I'm wondering whether at the 20-week scan, we should also mention the centile in terms of weight, because it becomes so easy to compare when we mention the centile at 20 weeks. So if I had, for instance, in this case, a 74th centile, and my weight had fallen to the 16th centile, then I know that I've not yet touched my 10th centile or 3rd centile, but I've fallen 2 quartiles. And I didn't have to go back to my original report to see how much it had fallen. So maybe it would be a good idea to also include centiles for weight in our 20-week scan.
Yes, and again, that is again a very, very important practical aspect is at whatever stage you do a scan, the patient normally after taking the report reads the report, and then they walk in and say, you've not given the fetal weight. So fetal weight actually becomes more of an entity which they want to live with. So we do mention the fetal weight and the centile even at the mid-trimester anomaly scans.
Yes, in fact, the same thing, when I was referring to the obstetricians having this concept so far of 37 weeks maturity and 34 weeks size, patients also understand that far better than centiles. Patients don't know mathematics so well. And so it's a good idea to mention from a patient point of view also that this is weeks and this is centiles. So let's move on to our next panel.
Yeah, we move to the next case. Saswati ma'am, if you can take this. Now there is a 29 years primary obese, 3rd cycle of IVF, early pregnancy scan, 8 weeks, CRL was 7 weeks, 4 days, and the dates were corrected. And 19 weeks, 5 days, she's come. And now this is what the biometry chart looks like. And you can see at 19 weeks, 5 days, as I said, sir said that even the figures matter, and you have an AC which is corresponding to 16 weeks, 5 days, it is less than the 1st centile, FL is less than the 1st centile, the fetal weight is at the 3rd centile. So, is this FGR?
Yes, it is. It is, because as far as the definition, at any point of time, if it is less than 3rd centile, the fetal weight, or then it is to be taken as FGR. But before that, I want to tell you that this particular patient has some factors. Like you say patient is obese, you say patient has undergone IVF. Now, these are the 2 factors which is in high risk factors for development of preeclampsia. So these patients, according to ASOG guidelines, they should be given beforehand, before 14 weeks gestation, an aspirin, because I think around 40 to 50%, and some says it is around 70%, they may develop preeclampsia in later on life. So to prevent that, and also because preeclampsia has an effect on the growth of the fetus, so we should also take care of that particular issues.
So you need a little more. Now the FTS, the first trimester screening at 11 to 14 weeks was done outside, and the NT was done, and it was a low risk. But at that stage, the uterine artery evaluation was not done. And see, a lot of times that happens that, not everyone has started putting it as a part of the protocol. And that is again a message that I want to give. In this case, as madam said, is already giving you all those high risk prompters. But even without, you would, madam, in this case, whether the uterine artery was done or not done, you would still start aspirin, right?
Yeah.
Yeah, you need to start.
Because they already in IVF and obese. These are the 2 factors.
Now, what else would you, now with this kind of findings, what else would you want actually in this patient?
I also want to know about because we know there are some causes for those, the early onset FGR. So there can be some genetic, we have said already, that has been excluded. And there can be some inborn errors of metabolism also that can cause this kind of problem. And some teratogen exposure, some radiation exposure, habit, smoking, drug abuse. These are the issues that you have to you have to take the history from the patients, where those factors and some factors which can be, it's possible to treat beforehand, as avoidance of smoking or drug abuse, those things that we can stop all those things. So lifestyle modification may be one of the issues that can be advised from the very beginning to rule out the causes. Yeah. So these information, the family history, the diabetes, whether the chances of diabetes is there, those issues also I want to lie. And in this case, I think there is a problem which is arising is because there is no secondary invasion of the trophoblast. So that will be reflected in if you do an uterine artery Doppler,
Yeah.
which will be reflected in that.
So structurally, everything was normal. There were no markers. There was nothing. But yes, very important thing. You have an fetal growth restriction of this kind occurring in the mid trimester. You need to think about the fetal cause also. Now, these are the Dopplers. You have a mean uterine artery PI, which is very, very high. And you have an umbilical artery PI also, which is more than the 95th centile. The MCA PI is also low. Forget the CPR here. But you have an umbilical artery, which is showing a high resistance flow. And so what stage is this?
I think this has gone to stage almost 2.
Why stage 2, ma'am? Because you don't have any absent diastolic flow. There is only high resistance flow.
95. Okay, this is stage 1. Yes.
This is stage 1. Any other investigations you would advise? You've already talked about diabetes and everything. Would you suggest an amniocentesis in this patient?
I would prefer, because the early onset IUGR is very, very, as I said, there's a metabolism problem and there's other congenital, I mean, the chromosomal defect and the, so I would definitely advise them that this is one of the possibility that you should go for, because there is a possibility that if you continue this pregnancy, the baby may have certain severe congenital anomalies. So that has to be excluded. So that investigation, even I want to do certain markers, the biochemical markers. I want to see the PAP-A level. The PAP-A level in the first trimester, that 11 to 13 weeks, that also tells us that what is the possibility of development of gross IUGR. The PAP-A has got certain the relationship with the development of IUGR later on.
Now, this is just 19 weeks, 5 days. There is significant IUGR. You're already seeing Doppler changes occurring at 19 weeks, 5 days. Would you advise termination to this patient?
I can't hear you.
No, I said she's 19 weeks, 5 days. There is a hello? Can you hear me now?
I'm so sorry, I can't hear you.
Others can hear me?
Yes.
Yeah, okay.
Have you, I think you have to unmute yourself. I can't hear you.
I am unmuted, madam.
Are you able to hear the others?
Yes, yes.
Okay, now can you hear me, ma'am?
Dr. Shashwati, are you able to hear us now? No, you're not able to hear us now, is it?
I can't hear him.
Oh, I see.
So
maybe...
Nilakshi, if you can hear, please carry on, Nilakshi.
Yeah, Nilakshi, ma'am.
Yeah.
Yes, Dr. Nilakshi. Now, in this case, 19 weeks, 5 days, significant growth restriction, umbilical artery PI high, things are not looking good. Would you advise termination to this patient?
So even if you advise, the patient is not going to listen to you because she is an IVF pregnancy. So it is not very easy to counsel the patient to go for termination at this stage. But prognosis definitely is very, very bad.
So you will explain the prognosis to the patient. So that's your counseling is all going to be about, how this could eventually end up with, and to the extent of that, yes, it could eventually land up into an early IUD also. So all those factors you're going to tell them, right?
Yes.
Okay. Now, when would you like to follow up this patient? This is stage 1, 19 weeks, 5 days. When would you like to follow up this patient?
Okay, I can hear you now.
When would you like to follow up this patient, ma'am?
This was 20 weeks, right?
19 weeks, 5 days. Yeah.
19 weeks. Now, ideally in stage 1, you can do it weekly, surveillance at stage 1. But here it is so early, I don't think I can call her after a month or so, maybe after 4 weeks.
Yeah, very true. Because what are you going to gain, actually speaking?
Yeah.
So here the protocol you have to leave aside because you're nothing going to gain. Like 20 weeks, 21 weeks, you do And so anyway, you're not going to get this baby out. You're not going to make any decisions.
Yeah, yeah.
So we called the patient after 4 weeks. Actually, we suggested all those tests. We suggested amnio and everything. But it was being such a precious pregnancy, the patient didn't want to do any other thing that was required. So we suggested, from my side, I suggested that we will do at around 24, 25 weeks after 5 weeks. But then the patient came after nearly 7 weeks. The patient ended up at 26 weeks, 5 days. And then that's the biometry that's taking place. Now the fetal weight is at the second centile. You can see the growth curves. The growth curves have dipped down. The fetal weight has gone down. And now the umbilical artery is showing me a reversal of diastolic flow. Umbilical artery is showing me reversal of diastolic flow. Aortic isthmus is normal. Ductus venosus is normal. So when I put the Doppler findings together, 26 weeks, 5 days, okay, this is fetal growth restriction. We have the fetal weight less than, all those things now don't matter. So you have umbilical artery reversed end diastolic.
So it is stage 3.
This is now stage 3. So
Yeah.
will you deliver?
Now, because still we have the ductus venosus is still normal.
Right.
So ductus venosus is still normal, I think, because 26 weeks is a time when in our setup, even in an ICU setup, it will be very difficult to salvage this fetus. So we have to, I think we can wait. And because it is stage 3, we'll call the patient again after, say, 1 or 2 days, or maybe a week after that.
Yeah, so we actually need to do a bi-weekly evaluation,
Right.
maybe every
Yeah.
2 days, 3 days. See, if we want to give the best chance to the fetus, we know we want to take them as close as possible to 28 weeks. So we will wait for the diastolic. So again, the staging, stage 3, we need to do it 1 to 2 days. But this patient was really, they once, because they had been so counseled about prematurity also and all, from their side, they were taking their own decisions. And so when we called them after 2 days, they came after 4 days. And now 27 weeks, 3 days, there is still, of course, there is reversal of end diastolic flow there. But now the aortic isthmus is showing a reversal of diastolic flow. And the ductus venosus PI is greater than 95th centile.
Still stage 3.
Still stage 3. Will you deliver? 27 weeks, 3 days.
Now, I think I also want to know whether the baby is moving or not, maybe a little bit about the biophysical profile. I want to see also whether the fetal heart, there is any kind of decelerations also. And I want to know the patient profile also, whether by that time she is already hypertensive.
She's not.
Whether she's having hypertension, yeah.
Yeah, she's not hypertensive. She's not hypertensive at this stage.
Okay.
Yeah. And
so I think we can wait till there is ductus venosus can tell us that we can wait.
Yeah. Even the NST, they say it was reactive. That's what was told to me. This was reactive again, but 27 weeks, 3 days. The patient still came back after 2 days. And after 2 days, there is a reversal of A wave in the ductus venosus. So now
this is, stage 4.
This is stage 4. So will you deliver?
Yeah. Now I think this is the time because we have I think within 1 day or 12 hours of the baby, there can be problem in the baby. So I think this is the right time we decide, we plan this. We have to plan to deliver this particular patient, and there is no question of induction of labor, because this fetus is under no circumstances going to take the whole process of labor. And we have to think of elective cesarean section in presence of good neonatologist with a good NICU. If the patient is a periphery, we'll shift the baby in utero to a better center.
When would you have given steroids to this patient?
Yeah, this is the time we give steroids, because we are planning 140. So 2.
You've got, madam, unmute yourself, please. Madam, you've got to unmute yourself.
Saraswati, better unmute kore no.
Anybody?
We missed your answer. You have to unmute yourself.
Can I just pick up the question?
Yeah, please.
Can you repeat your answer, please? About the steroids, we missed the answer completely.
You have to unmute yourself. Unmute yourself.
Now you're muted. Now
Yeah,
that's
yeah.
good.
Yeah.
Can you give that answer again?
Yeah, I want the answer. Okay.
About the steroids.
Yeah, steroids, we have to give steroids and we have to wait for at least, because we need 2 doses to be given, complete the 2 doses. And we also give the magnesium sulfate. Magnesium sulfate, this will reduce the incidence of the cerebral palsy, neuroprotection.
So would you have given that?
Less than 32 weeks.
Would you have given that, a week earlier when we were already seeing reverse end diastolic flow and this thing, or you would give it now?
I think we'll give it in where we have seen that this is going to the reversal of diastolic flow in the aortic isthmus, and DUCTUS VENOSUS was showing that 95th percentile. I think that is probably the right time to give that magnesium sulfate and steroids.
So now in this case, a 485 grams female baby was delivered by LSCS. This baby spent 40 days in NICU and went home. The last I know means, means at least 3 to 4 months after that, the follow-up that I could get was the baby was still doing well. And so the lesson learned is that in early onset FGR, before 30 weeks, the critical endpoint should be a significant abnormality in the ductus venosus. Every day in fetus, the fetus spends in utero before 28 weeks, reduces the morbidity by 2 weeks. And Krana sir, your quick comments on this, sir.
2 things. One, that we should follow the protocol. It's a great guide. Second, there would be patients who will make their own choices, but we must offer it to them and we must counsel appropriately. Counseling is extremely important. She says no to the amniocentesis. That is her choice. It should be documented. The next thing is this question of the risks of when should we deliver. Should we have delivered her? Suppose her relative reads on the internet that 26 weeks is fine in the United States of America. We have to explain to her that that does not refer to a good statistic for intact survival. The chances of that baby would have an abnormal neurodevelopmental outcome is huge until about 28 weeks, and therefore we're trying to stretch it. Would she like to stretch it or not? So that counseling becomes important. The rest now, as we've learned, is straight away protocol based. And if you're planning to deliver within the next 1 week, it's a good idea to pop in the steroid anyway.
We move to the next case.
I just want to add one more thing. There is other markers for this preeclampsia or IUGR. That is an angiogenic marker. So you can do that ratio S-FLEET and PLGF, which is available nowadays. The ratio between S-FLEET becomes higher, this anti-angiogenic. So that also can be done in this case. So I forgot to mention that.
Yes, that would be useful in case it was preeclampsia. We haven't really proven its use in fetal growth restriction so far, of course.
Yeah.
Now, this case, Dr. Bhattacharya, if you can take this, 28-year-old second gravida, she's come for a scan at 29 weeks, 5 days. Fundal height is 28 weeks. Now, she has a history of hypertension from 26 weeks in her previous pregnancy, in the first pregnancy. And she ended up with an emergency LSCS at 34 weeks of gestation. The fetal weight was 1750 grams and the baby is currently alive and healthy. Her mother was, the patient's mother was also hypertensive. So that is a history. The background is this. Now, the NT scan at 12 weeks, 3 days was corresponding to corrected dates. And of course, the NT and everything was normal. The mean uterine artery PI was 2.95, which was increased. So, my question to you is, should a PAPE and PLGF be added to the mean uterine artery?
Yes, sir. Yes, sir. PIGF and PAPE is to be added in this patient because it is a high-risk case. Mother was hypertensive and patient past history is also hypertensive, and she delivered. She was forced to deliver early. So we'll have to send this investigation PAPE and PSF. It's must.
So a combined thing with uterine artery, with PAPE, with PLGF, with maternal blood pressure, and all those things put together, definitely the sensitivity is.
And we'll add some drugs also, like high-risk case for hypertension. So we'll have to start aspirin in a dose of 150 milligram at bedtime. That is the recommended dose. It's already okay.
What is the recommendation? I was going to ask you the same thing. Thank you. You've already put it across to me. So, but
regarding controversies, 150 milligram is the dose. that is given in outside. But in Indian standards, we have not estimated. And in some journals of American College of ONG, they have given 81 milligram or so. But in our country, it's better to start 150 milligram as their studies are pending.
Yeah.
150
But,
day.
But you know, in this case, with the history of previous pregnancy with PIH, and then mother also being hypertensive, there is a strong history. Would you wait for the 12 weeks scan and the uterine artery and the PAPE and PLGF and then start, or would you start aspirin much earlier?
Yeah, we should start from the first trimester itself. Actually, if we get this case in the preconceptional period, it is best, because preconceptional counseling is yet to develop in our country. There are some preconceptional clinic. These cases should undergo preconceptional counseling and periconceptional care also, like folic acid aspirin.
Yeah. So 20-week scan was also corresponding. There were no structural anomalies, no second trimester soft markers. The PI, of course, uterine artery was increased even then. Now, in light of our history and you know, of hypertension and FGR in previous pregnancy, when would you recommend the next scan? When would you like to start the growth assessment in this particular case?
So considering the history of this patient, we should advise the next scan at 28 weeks. If possible at 24 weeks, but 28 weeks is must. Yeah.
So we suggested at 28 weeks, but the patient came at 29 weeks, 5 days. And at 29 weeks, 5 days, there is, you have the AC at the 17th centile, and the estimated fetal weight is at the 5th centile. Umbilical artery PI is high, and so you have a high umbilical artery PI there, increased this thing. The maternal blood pressure is 170/96. There is fetal edema, albuminuria. And so what stage is this, sir?
Stage 1. It's stage 1. We should follow up the case every week.
So we need to do a follow-up.
Next week we'll have to call the patient the next week, and considering hypertension, she should regularly examine her blood pressure. That is morning and evening time.
Okay.
Because hypertensive.
Yeah, because it's stage 1 anyway, we are not thinking of delivering or anything. Now she comes at 30 weeks, 6 days. At 30 weeks, 6 days, again, the parameters are, the fetal weight has now gone to the 3rd centile, but umbilical artery is still showing a high resistance, there is no absent diastolic flow and everything. So this is again stage 1.
Stage 1.
Yeah, so,
next.
And the maternal blood pressure is 180/100. So you would like to follow this up?
After 1 week?
One thing I must tell, that this patient, when she had 170, 100, she won't be back to her home. She'll be in the hospital. That is most important.
Hospitalization is must.
170, 100, she may go for any other problem, and I will not allow that to go for a fetus, because fetus is not the matter. The mother is also matters in this case.
So this patient was admitted and was under hospital management. And at 31 weeks, 6 days, you still have the umbilical, the Dopplers showing the same kind of a picture. You have, you know, the fetal weight, of course, is there. So this is still stage 1.
Yeah.
So would you like to wait after a week? What next?
If her blood pressure is much more, so we'll have to consider in that case. If the blood pressure is much more,
So
if the blood pressure is this much, we must terminate the pregnancy after counseling, and for that we'll have to give antenatal steroids and proper counseling. As she's lucky that she has got one baby, because in this BP we may lose the baby at any moment. That is the problem. So we should deliver the patient, and preferably by cesarean section.
So the lesson learned is
maternal condition is.
So what ma'am said in between was that maternal condition supersedes everything. So all these staging and protocols go for a toss. The mother is the one that we will bother about primarily. Now this is, Dr. Ruby, can you take this case? This is a 25-weeker sent for an anomaly scan because she had missed her 20 weeks TIFA scan. The dates were corrected with the early pregnancy scan, which was available with the patient. There was only one scan available with the patient. The patient came to me directly at 25 weeks, 1 day. And there you can see the AC is very, very low, it's in fact less than 4 standard deviation there. the fetal weight is less than, is at the, the second centile. And so look at the Dopplers, uterine arteries, of course there is increased mean uterine artery PI. Umbilical artery is showing absent diastolic flow. Ductus venosus is normal. Now, my question to you is, okay, I put this, so 25 weeks, 1 day, estimated fetal weight, second centile, you have an absent diastolic flow. So what is the stage now?
So this is the stage 2, stage 2, and definitely we are going to advise her every third day or maybe twice a week monitoring with Doppler.
So you would monitor bi-weekly, you would like to monitor, because this is stage 2.
Yes.
Now, okay, this is still there. Now she comes, the patients don't listen. A lot of times, like in my practice, I've seen that even our clinicians don't want the patient to go for scan every 2-3 days. So this patient comes to me after 1 week. There is absent diastolic flow. Ductus venosus is still normal. So definitely.
She is still stable at stage 2 because ductus is still normal. Umbilical artery is showing absent and no reversal yet. So she's still in stage 2. So we'll be following her up again by.
You want to put her into a very, very, the surveillance has to be very, very strong at this stage.
Yes.
So now she comes at 27 weeks, 3 days. We still have the same finding. There is still an absent diastolic flow. So
yes, we are going to follow her up very closely, twice weekly with Doppler.
Okay, 28 weeks, 4 days, NST at 28. So this patient actually, rather than coming to me for every second or third day, what they were doing was they were doing a midweek NST and a weekend Doppler. So a midweek NST and a weekend Doppler. So the NST at 28 weeks was reactive. So this patient comes at 28 weeks, 4 days to me. It's still absent diastolic flow. Ductus venosus is normal. So 28 weeks, 4 days, stage 2. Would you like to deliver?
No, sir. We'll still wait.
We'll still wait.
Yes.
Okay. Yeah. So she comes at 30 weeks. NST at 39 weeks, 2 days was reactive. Umbilical artery is now showing reversal of end diastolic flow.
Right.
And the ductus venosus PI is greater than the 95th centile.
So now she's in stage 3 now.
Yes, stage 3, will you deliver?
Yes, definitely. Once there is reversal at the umbilical artery, we are not going to continue this pregnancy beyond 30 weeks because that will be very risky. We are going to deliver it by cesarean section.
Yeah. So somebody may question me that the ISUOG guidelines now say that 32 weeks reversal of end diastolic flow you can, but if you read it properly, can be used at 30 weeks also. That is even the truffle trial, when they had this safety net, the safety net was at the 30 weeks, it was reverse end diastolic flow. So it is 30 weeks now. There is a reverse end diastolic flow. So we need to get this baby out. And the lesson learned here is that a fetus can pull on with absent end diastolic flow for a long time. Very important thing. So, you have an absent diastolic flow, 27 weeks, you don't need to hurry up. Yes, put them on a much closer surveillance. Follow them up. Keep monitoring the ductus venosus. Yes, if it's past 30 weeks, we're not bothering about the ductus venosus at that stage. Even after 30 weeks, if there is a reverse end diastolic flow, it indicates adverse perinatal outcome, and that is more risky than prematurity. Hence, early delivery is justified. Experts.
Fabulous. We all speaking the same language. I think we couldn't ask for anything more. And we do agree that there is a fine print in the ISUOG guidelines, and we must read the fine print. And otherwise we will be lost. We are not lost with the Barcelona guidelines. We've tried and tested them for the past 6 years. They've worked. They've given us the best results, and that's what you and me should follow all the time. whether we're sonologists, whether we're radiologists, whether we're fetal medicine, or whether we're practicing obstetricians, we have something which is a common language with excellent results for the fetus. We must stick to it.
I
Now-
wish all radiologists give the same type of reports to us so that it becomes so easy for us.
Yes.
Actually, you need to demand more from your radiologist, ma'am.
Yeah, I think so.
See, I always feel the quality of an imaging specialist depends a lot on the quality of his referring doctors also. So unless you don't ask more, we are not going to improve. See, we are all human beings. If people are happy with whatever we are giving, then that becomes, people become very, very lazy. So I feel all radiologists who have referrals coming from obstetricians who are well-read and who are very rigid and demand more, they are the only ones who actually have progressed rapidly, because they were asking more and more questions. So there were only two choices left with the radiologists. Like for me, I was also very lucky, because I had only two choices. Either I stop getting patients from them, or I go and learn and improve myself. And I took the second option. And that's why, so I think that's a very important point. We need uniformity, very true. It has to be a uniformity. And secondly, all radiologists also need to realize, not necessarily radiologists, all imaging people, because we have a lot of obstetricians into imaging now, is that we are a part and parcel of the decision-making team. See, a lot of times we feel, okay, I've given the PI, I've said this PI is high, this PI is more, and I leave it, okay, let the obstetrician now take a call. No, it's not like that. It is a teamwork, and we need to, as sir said in one of his comments, there has to be a communication. There has to be a communication between the imaging person and the obstetrician. We are all a part and parcel of the team. Even like if I send and I say this is stage so and so, and a lot of times my obstetricians call me up in the evening and they say, okay, but what exactly are you trying to mean out of that? And then we discuss and I explain it to them. This is what it goes about. So there has to be a constant communication between the two. So now I come to a tricky question, is because there are studies for and against it. Should a multi-vessel Doppler be a part of every growth scan? And for this, I will show you a case and then we will come to this. This patient has come to me at 34 weeks, 6 days. The AC is 21st centile. The fetal weight is also within the normal range. Now, Dr. Nilakshi,
Yes.
I will also tell you that at 19 weeks, 1 day, the scan which was done at other place, I have put those findings in my, fortunately I use a software, I can put in the external findings. And that time, yes, everything was corresponding at the 50th centile, and the dates actually even right from the beginning have been corrected. So there's no problem with the dates. And so now I want to ask you, should I or should I not do Doppler? Because this is just AGA fetus, 34 weeks, 6 days.
Ideally, all growth scan, we should have a Doppler study of the multiple vessels. That is the guideline. So
I'm very happy. Even the guidelines are conflicting at so many places, but I'm very happy that you say that, yes, we should do a Doppler. And I have done a Doppler in this case. The mean uterine artery PI was high. The umbilical artery PI is at the 70th centile. The MCA PI is at the 13th centile. The CPR is 1.38 and which falls at the 6th centile.
Yes.
So, is this fetal growth restriction?
Up to this point, I will not label it as a case of FGR.
Yeah.
Follow
But are you worried? Or
Yeah.
will you? Yeah.
It might go towards the late onset IUGR, so we'll follow the case.
We follow this case.
Yes.
So now I called this patient after 2 weeks, and after 2 weeks, she's 36 weeks, 6 days by corrected dates. Now the AC has come down to the 16th centile. It has not gone down 2 quartiles from anywhere. And you have the fetal weight now, which is at the 5th centile. Umbilical artery PI now has increased more than 95th centile. It is just showing a high PI. MC, and the CPR now is less than the first centile.
Yeah. So this is this is the area we should focus when we look at the late onset IUGR. Apparently, umbilical artery PI is here is slightly higher.
That is fortunate that it helps you in making a decision because the umbilical artery PI is there. But you may still, you could have an umbilical PI which could actually have been at the 90th centile. But what is important here is that the CPR has dipped in from the 6th centile to less than first centile over a period of 2 weeks. So the patient was advised delivery. In fact, I had a talk with the obstetrician. The patient was counseled. The patient went next day. She was 37 weeks on that day. The patient was suggested delivery. But then whenever you say something, patient always wants to have a second opinion. The second opinion, unfortunately, went to a very, very senior obstetrician. And the senior obstetrician, with her own acquired wisdom on the Dopplers, where they always go through a cascade, explain to the patient it is just high now, it will become absent, then it will become reversal. So there is nothing to, these young obstetricians are always in a hurry to deliver. There's no problem. Let's repeat after 10 days. Now, with all that confidence, the patient thought, why 10 days? Let me come after 2 weeks, and then they came to me after 2 weeks and there was an intrauterine demise. Now forget, that is an unfortunate part that this has happened. So, but what I'm trying to say is that at 34 weeks, 6 days, if I would not have done the Doppler, if I would not have found the CPR which was at the 6th centile, okay, though it was not less than the 5th centile, but it was very, very close, I would have not probably asked the patient for a repeat scan after 2 weeks. And because I asked the patient after 2 weeks, I could pick up. Otherwise, this patient anyway would have gone to 37, 38 weeks and would have gone. Unfortunately, this has happened here. But if we could have delivered this baby at 37 weeks, this baby could have been survived. So in late onset FGR, the estimated fetal weight may not necessarily be less. So it can go, as I said before, an AGA at 32, 34 weeks can become SGA later, or it may still remain an AGA. Umbilical artery can be normal. It will not follow the cascade of events what it does in early onset. The CPR ratio is a critical index in late onset FGR, and a multivessel Doppler should be a part of every growth scan in the 3rd trimester. Experts' comments on this, sir.
Bimal, thank you for this presentation. It brings forth some very, very serious, straightforward points on how we can save more babies. We must accept the fact that the quality of ultrasound in our nation today is amongst the finest.
Sir, I have one more case to show.
Yeah, but before that, we must say here that this business of multi-vessel Doppler is extremely important because each reflects a different circuit. We know that in average for gestational age, with an abnormal Doppler, even if you have an abnormal MCA Doppler without an abnormal CPR, there will be a 15 to 40% chance of an intrauterine demise or a perinatal event that is unfavorable. So it becomes very necessary that routine growth scans at 30 weeks or 32 weeks, a routine growth scan at 36 weeks, and both of these should include a multi-vessel Doppler, and I always include a uterine artery as well.
Now this case is an open case. I just want to show, because this is something which I have experienced. Now this patient came to me for the first scan at 31 weeks, 5 days. And look at all the parameters. They're all 31 weeks, 31 to 32 weeks. Wonderful AGA, in fact, everything at the 50th to 60th centile. You look at the biometry, everything absolutely looks normal. But when I'm doing the scan, I find there is a minimal ascites. I find that there is cerebral edema. The IVC and SVC are dilated. There is cardiomegaly there. Now, this is, the patient had not got their earlier reports also. So actually, we normally do not give the report till they bring their previous file. So in the meantime, the husband had gone to get the file. And this patient comes with the file. And then I saw all her previous reports. when the menstrual age was 28 weeks, the ultrasound age given was 29-30 weeks. And it was 29-30 weeks and it was reported as 29-30 weeks. At 20 weeks, it was 23 weeks and it was reported as 23 weeks. And at 7 weeks, it was 11 weeks, 2 days. It was reported as 11 weeks, 2 days. The dates were corrected. It was given as wrong dates. But now the same person has done the next 2 scans. The obstetrician is also the same. But all along, nobody actually is bothering about, that nobody is working on the dates based on the corrected EDD. And now when I correct the EDD based on the early scan, I correct the dates and I find that everything, yes, this is significant fetal growth restriction there. And when I look at Doppler, there is a reversal of diastolic flow in the umbilical artery, there is reversal in the aortic isthmus, and there is reversal in the ductus venosus. Now, of course, an immediate LSCS was performed after 2 days in an ICU. The baby could not be saved. The baby succumbed. So my question is, don't you think it is iatrogenic? Don't you think we are responsible for this?
Absolutely.
Could this baby had a better outcome if the basic principles of dating and gestational age would have been followed? And so I come back to the same point that, forget the Dopplers, forget everything. First, get your dates correct. All these findings of your estimated fetal weight, even Dopplers are based on percentiles for that gestational age. And that is why, and in this case, because the radiologist who was doing the scans never bothered to look at his own previous scans. He himself corrected the dates. That went wrong. The obstetrician, okay, right? At the moment the dates were corrected, they should have put it, the EDD at the top of their file. And every time the report was coming, they should have bothered to look at the things and say, oh my God, because if this baby had been labeled as fetal growth restriction, even 2 weeks back, forget the, even 2 to 3 weeks back, then probably the Dopplers that time would not have been that severe and the baby could have been saved and this thing. So correct dating is the most important aspect. And once dates have been corrected, all further scans need to be correlated with the corrected EDD. And this is the most important message I want to give from the last 1.5 hours that I've been speaking, putting everything together, because everything else will come. If you don't know your dating well, forget doing Dopplers and everything, leave it for the next 2 years. First, get your dating correct, learn the basic principles of dating, learn this basic concept that yes, and the gestational age is the most important factor, and then come and try learning other aspects of this. With this, I leave the platform to Dr. Khurana for his final comments on the whole aspect of fetal growth restrictions.
Sir, can I say just take 1 minute, sir?
Yes.
Yeah.
Sir, can I take 1 minute?
Yeah.
Yes, please.
Yeah, I just want to say a few words about the AFI, the amniotic fluid index,
Yeah.
which is considered a component of BPP or the biophysical profile. But studies and meta-analysis have shown that the role of oligohydramnios in predicting adverse fetal outcome, as well as predicting perinatal morbidity and mortality, has been seen to be very negligible. So probably that's why the AFI has not been incorporated in the space-based management protocol of FGR. But in the clinical scenario, we often say that most of the clinicians, many clinicians, they get worried, like they get tensed up when they see that there is decreased lipo volume, and some even wish to deliver the fetus early just on the basis of decreased lipo volume. But that should not be the case unless and until the Doppler criteria suggest us to go for an early intervention. That's a message I actually want to give to the radiologist as well as the clinicians. Am I right, sir?
Yeah, Ruby, you're right. The fine print there is that those pregnancies which are being monitored by Doppler and maybe computerized CTG, or then in those cases it has been found that an oligohydramnios did not correlate well with abnormal outcome. Right. So that is a fine print there. And yes, of course, a good liker gives you all it always makes you more happy. You're quite relaxed with those things. But yes, oligohydramnios in a setting where you are already monitoring the whole thing based on Doppler and CTG is the place where it does not correlate well. Sir, you feel something else?
No, this is absolutely fantastic, and I'm glad that last bit came because that was a question as well. And Ruby has already pointed out that we started with subjective amniotic fluid, then we moved on to pocket, then we moved on to AFI, we moved on to 2 pocket, 1 pocket, and finally we dismiss it from our armamentarium because we don't depend on it anymore. Bimal, this was an absolutely fabulous exercise, and I congratulate you and the panel for having put this together in such a fabulously crafted way and really clarifying everything for at least 1 year to come. Concepts do change every day, but we're quite happy to change our concepts if we learn more. But let's face it, we've been following these, you and me have been following these for over 6 years now, thanks to Professor Gratikos's frequent visits to India, and it's really worked very well. And thank you so much. We will put this onto the SFM YouTube channel, and you can actually access it via the SFM website. If you're not a member already, please do join us. I'd also like this chance to thank Dr. Shyam Baruah for inspiring everybody who's doing fetal imaging today to produce the most exquisite images that we have probably ever seen for that particular subject. This is way beyond world class, and thank you, Shyam, for always leading by example.
I'm going to borrow a few from him.
We will now use them as our own property and get credit. And Gina and the entire Assam team has really put forth so much into this that I really can't thank them enough. We look forward to many more quarterly meetings,
Thank you, sir.
as well as other meetings, and we'd like to see even more panelists. We obviously have wisdom there, and I'm so glad the rest of the nation shared it today. There was a time when we included our Facebook attendees, we had over 400 attendees, and that's really marvelous for a regional meeting. And let me also take this chance to thank Vishal from the SFM head office, who is always there to help us out and always there to help everybody out, and Sumit Bhai from Conferences International, who does all our virtual work and on-site exhibition work as well. For all inquiries regarding the YouTube channel, we have Faisal Khan in the office, and he handles the journal as well. So we have the whole team set for you. Please do use it, and I look forward to everyone making full use of this. And back again to Gina for closing words.
Before that, I think we have extended far beyond the schedule. And I think most of the questions have been answered, and a lot of questions Khurana sir has already answered in this. But if still people have any questions, my phone number is 9823550582. And if they can WhatsApp it to me, I will answer those questions in the next 2 days. Any specific questions for that? Okay.
Thank you very much.
Thank you.
Okay, I think that brings us to the end of our meet. Yeah, okay.
No, I just wanted to thank all of you, and especially for all those, we have also learnt a lot, the whole concept of IUGR.
Yes,
thank you so much.
Yeah.
Thank you, ma'am. Thank you.
Thank you, sir. Thank you.
Thank you, everybody.
Thank you, everyone.
Thank you. Thank you. Good night.
Good night. Good night.
So I'd just like to thank everyone for an excellent academic program, and also the Central Committee members of SFM, Khurana sir, TLN Praveen sir, then who's the President and Vice President, Dr. Mohit Shah, then General Secretary, Dr. Krishna Gopal called me. And they've been constantly supporting us and guiding us for our regional chapters. And I'd like to thank our team members of the SFM Assam chapter and our trade partners like Cell Diagnostics and Mindray. And nevertheless, all the attending delegates for taking time out on this Sunday evening to attend our program. And so good night, everyone. And goodbye with the promise of meeting again very soon. Do stay safe. Good night. And thank you so much, Khurana sir, and thank you so much to all the teachers. Thank you so much.
Good night. Thank you.
Good night.